Colleagues, we are going to start the meeting. Thank you very much for your attendance. Very nice to see so many members of the public here this afternoon. This meeting is going to be live streamed and is being undertaken remotely. So, colleagues, please bear with us if there's any issues. You know, you are being filmed here, so wherever it is, somewhere, it's up there. But there's no microphones on the table for this meeting, so I would ask that you speak up clearly, you know, and loudly, and those microphones that are in the ceiling will pick up the sound for the live stream. So hopefully that's okay with everybody. Very much. So just go back to the agenda. Welcome and introductions from myself. As I said, welcome for everybody. I've got a few points that I need to make. You'll be aware, colleagues, that we have appointed a substantive chair for the ICB, and that process is still going through. It has to be signed off by the Secretary of State. Some of you may notice that there has been a change of administration down at Westminster. So I guess the new Secretary of State will be taking that into consideration when he gets through his inbox, and which I guess is pretty full at the moment. So unfortunately, that's sort of, we're waiting for that to happen. But we look forward to meeting and introducing our new chair when they arrive, and I'm sure hopefully that won't be too long. Okay, thank you for that. So just want to mention in the meeting a few things to place on record on behalf of the board. Some of you will remember Dr. Jeff Jolliffe, who was our partner member for primary care, and he recently attended his last meeting as his tenure in that particular position. And on behalf of the board, I'd like to place on record and convey our thanks to Jeff for such a huge contribution that he made to the ICB, and his passion, as I think all of you know, for primary care was phenomenal. And we will ensure we continue that good work that he brought along is kept in place. So I'd like to thank Jeff, as I say, for what he did for us. And I think we should also recognise as well that as from I think it's next year, he is becoming the High Sheriff of Cumbria, and he has indicated to me that he wants to come to the board in his finery to show us all what he looks like as that High Sheriff, and he'll be bringing a sword. So I hope you all behave yourself. So that should be something we should all look forward to. I'd also like to welcome at this juncture Dr. Julie Colcliffe. Julie, welcome. And Julie's recently been appointed as our new partner member for primary care, so we welcome you, Julie, and thank you, and welcome to your first meeting of the board.
What a high bar to set.
No, it's fine. Some of you know that our people officer, Lee Radford, also attended his final meeting. He's taken up a role as the chief people officer at NHS Derby and Derbyshire ICB. So again, I'd just like to place on record our thanks to Lee and wish him well in his new role. I move now to Angie as well. Angie, on behalf of the board, I'd like to convey our thanks to Angie. Angie's been a long-standing member of this board and moving on to be the chief executive of Hertfordshire County Council, I understand. Is that correct, Angie? Yeah. And she's provided outstanding leadership at the council. I'm very aware of that. And we're very grateful for the support and forward thinking of your contributions to the ICB board. So thanks, Angie. So replacing Angie, we will have Denise Park. Denise is the chief executive of Blackwood with Darwen Council, and she has got to join the ICB board as the partner for local authorities. Denise has unfortunately had to send her apologies for today's meeting. So we thank you, Angie, for attending in her absence as a partner member. Thank you. I'm going to carry on. Abdul Rakit Razak was the local government representation on the board for public health. Abdul attended his last meeting in June, and so I'll place on our record our thanks to Abdul for his contribution to this board. And at that juncture, I welcome Sakti Karunati. Welcome, Sakti. I've known you for a long time, and very much welcome you to our board. He's Lancashire County Council's Director of Public Health, and he's going to be a public health participant on this particular board. And I just lastly like to also welcome Catherine Disley. Catherine's here, who's standing as our Director of Operational Finance, standing in for Sam Prophet, who's had to give apologies today, and Stephen Downs, who's attending for the ICF deficit position NHS England intentions item. Finally, we also welcome Anthony Davidson. Welcome, Anthony. He's Director of Nursing and Quality of Commissioning and Integration for Lancashire and South Cumbria NHS Foundation Trust. And you're observing the meeting as part of your professional development while shadowing Sarah O'Brien. Welcome. Thank you. We have no public questions that have been submitted to the board since it last met, which pertain to items on the meeting's agenda. And further details in this regard can be found on page 6 of the papers. At page 6, we have the patient story, and we'll come to that when we go to that particular item on the agenda. So that's me going through all the introductions and welcome. So thank you very much, everybody. Apologies for absence. We have a few apologies. Louise?
Yeah, Sam Prophet, Chris Oliver, Aaron Cummings, Kath Worley, Denise Park, Vicky Gant, Deborah Atkinson.
Okay, thank you for that. Any other apologies you need to be aware of? Anybody who no? Any verbal apologies? No? Okay. Declaration of interest. They are as on the actual. If there's any changes to those, please let us know. And if anything does come up during the meeting, please make us aware at that particular juncture what that declaration is, and so we can include that in the minutes. Okay, so much. So we have the minutes of 2 previous board meetings and matters arising on the 15th of May 2024 and 19th of June, which is an extraordinary meeting of the board. There have been some very, very minor amendments to those meeting minutes, and whilst they don't affect actually the intention of the minutes themselves, you'll probably note when they come back out again, there are some very, very minor amendments to those. So just to make you aware of that. Okay. So anything on the minutes of the meetings? Anybody got anything they wish to raise? We're happy to accept those. Agree those? Yes, that agree? Yeah. Thank you so much. Okay. I'm to take you then to the action log. 4 items on there, and got children placed in appropriate settings. We're proposing to close that. That's on the agenda, I think.
We took it in part 2.
We took it in part 2. We've had that discussion. Health inequalities, again, we took in part 2, so we're proposing to close that one. Urgent and emergency care recovery and winter update. Proposing to close that as well. And the last one is the deterioration in life expectancy figures relating to growing health inequalities. Was a meeting of the Director of Public Health at the Clinical Assembly in June, and we're going to have further discussion on that at a future board meeting. David, do you want to comment on that?
In fact, this is quite timely because we've got the Prevention and Health Inequality Steering Group for Lancashire and South Cumbria tomorrow afternoon. So what we will do is we'll take that through to that meeting, because I think it's quite important to understand the significant changes in life expectancy and healthy life expectancy post-COVID and what's the impact it's having on our population.
I'm the only one who can't hear.
Can't hear.
Can't hear, I'm afraid.
Sorry.
Okay, so let me start again.
I've
So
been
my apologies. It's partly, I think, it's the acoustics of the room. So
Well, usually you've got the microphones, but
I know.
of course today.
and I think we all need to make sure we're talking to our public. Okay, so my apologies. So there's a meeting tomorrow, the Prevention and Health Inequality Steering Group, where the Directors of Public Health come together with the ICB, and we will pick this issue up there. It's a really important issue because we're seeing a decline in life expectancy and healthy life expectancy post-COVID, like other parts of the country. But there are other features impacting on our population which are different from other parts of the country. And we would welcome the opportunity to bring back a presentation to a future meeting.
Thank you, David. Can I reiterate my earlier comments about people speaking up?
So I thought that's
Yeah, I know we're trying to, but I hope you can hear myself. Is that okay? Yeah. Anyone, please let me know if you can't. I'm usually pretty
We see the
verbose.
microphones.
I know microphones would have been better, I must admit, but unfortunately we're not able to provide those today. Okay, so thank you for that, and welcome again to the new members. We are all on friendly terms here. We're all on first name terms, so yeah, please feel free to do that. So we're going to move then to the standing items, and the first item is the report of the Chief Executive. Kevin, thank you.
Thank you, Chair. I hope you can hear me okay. Good afternoon, everyone. Really just 3 points. Obviously, we have a new government following the election. It's very early days, but what is already clear is they've made public announcements that there will be no significant structural change and they will be living within the existing financial envelope. So we really need to focus on, as a system, on what are the opportunities to do things within the existing framework, faster, better, smarter, and cheaper. And are there going to be any new opportunities with the government, a new government and a fresh approach? So we need to have that in mind. Point number 2 is we have gone through the assurance process with NHS England, and the Chair and I have received a letter on that, which I will circulate to board members. And number 3, just to note that we did complete 2 very significant transactions on the 1st of July, which was the transfer of the CAM service from East Lancashire to LSCFT, the Mental Health Trust, and the transfer of community services from Lancashire and South Cumbria Foundation Trust to ELHT, East Lancashire Hospital. That's something that's been talked about for years. It's been done. It was done on time, to budget, and without any surprises. So I'd just like to say well done to everyone. They are 2 very significant transactions, and I think everyone should feel proud of the way that was done. That's it. Happy to answer any questions if people have them.
Okay, thank you. Good. Any points or questions on Chief Executive's report? Had the opportunity to read that, obviously, put it in the papers. Okay, thanks so much. So we're going to move directly to item 6, which is the patient story citizen voice. Sarah, you're happy to introduce this? Yeah.
Yes, thank you, Chair. Just a couple of words, and we are hoping the video's going to play, because normally Mark does that. But the video today is actually, it's a number of people speaking about both their experience, but also what good community services would look like. And this video was made and played at a recent event we had around our transforming community care services and the work we're doing. And I thought it was a really good one for today, because it's very pertinent to a number of the agenda items later on, such as the system recovery and transformation, because this year and our longer run focus on community services is key to system transformation, but also the urgent and emergency care recovery and update is also, community services are absolutely key to that. So I think it's a really powerful video on hearing from a collection of residents' voices across the patch of what good community care looks like, and we will absolutely be taking on board what they're saying as part of to take that into those community transformation work that we're doing.
Thank you, Sarah.
I think Anna's going to try and play it.
On the video.
The community needs to be close to people where there's public transport access. It needs to be holistic, so it needs to cover everything from physical health, mental health, social health, which help people in your community.
I think that's important, that if you need them to come to you, they do. And if you can get to them, then great.
You also need it to be joined up. Very often, patients might feel that it's just the NHS, whereas you do get to be the ones who are in the system, but it's the GP, it's the district nurses, it's the hospital. The best care I've ever seen in the community is the IHSS who come into your home when there's a crisis and help put everything together.
Well, if services would be easy to access and easy to get information about what their services are.
So I think what would help us stay happy and healthy at home would be having someone to talk to. If you get lonely, that can cause mental health issues. So having someone to talk to, or just friends in the community, and being able to go out and enjoy yourself. Even someone like here, we're in a community centre today, and just coming down here and talking to people, that is so good for people's mental health.
One of the major problems with the healthcare system is that finding the right help. What I would like to see is one named person that you can contact, and they would be responsible for putting you in touch with people that help with benefits, or with social prescribing, or with a gym class that might help you in case you've gone to falling.
The more you can do for yourself in the community, and maybe sort of just finding something to do, so having an activity to go to once a week where you see your friends, or having support to eat healthily, or talking about your well-being a bit more. Actually just talking can be a massive thing.
Thank you, Chair.
Okay.
So I don't think there's much more to say, but I think very powerful, and we will be taking all of those things and other work that we're doing on board as we do the community transformation work.
That video actually was presented at Care in the Community Transformation Workshop, and that's collated by our local Health Watch. So our thanks go to Health Watch for that work that they've brought in on that. So thank you. And it was it was about what matters to local people. We've got a number of local people here with us this afternoon. So in relation to care in the community, it was used to set the scene for the collaboration in that particular workshop. So are there any comments or questions on it? Yes, certainly.
Thank you, Roy. What was coming across over to me was, as much as people valued services going into their homes and having a named contact, what was overwhelming in that was people really value not just the care services, but something meaningful to do and engage in communities that is not really related to clinical care, but the wider well-being. And that seems like an opportunity for us to jointly focus between the hospital program and the community program, and particularly leverage what's out there in our voluntary community, faith and social enterprises. It just highlights the need for us to have a shared investment strategy. It might come at a small cost, but it could lead to a lot of improvements in well-being and indeed money.
Okay, thanks, Sandy. Any other comments? David? Yes.
Yeah, just a similar point, really. I mean, what stands out is that people aren't talking about the NHS there. When you ask them what they want, they're talking about love, they're talking about relationships, they're talking about connection, community, housing. They're the things that really matter to people. And if we get those things right, then their need for the services that this board manages, it diminishes, doesn't it? So I think it's really obvious from people what they're doing there.
Okay, Tracy.
Thanks, Roy. Obviously, I will agree. Thank you, Saxby. Thank you, David. I think for me, it is loud and clear that this is obviously about that holistic approach to people, and not about treating medical conditions in isolation of thinking about the whole person. But I think there are so many assets out there in the community that as an integrated system are right for us to really understand where they fit in and how we can make best use of them. And I don't think it's always about further investment. I think it's about wise investment, and also understanding what the assets are doing at the moment and how that can be geared a little bit more towards us understanding that whole people's health and well-being. So I think sometimes we think, and often as a sector we get criticised because people think we're saying, please invest in us, invest more in us. And actually I think that is a different message, certainly from the sector that I represent, that it's about us understanding what's working out there in the community and making sure that's targeted investment, and also making sure that we really understand how much of this is actually going into the prevention agenda, because there's a huge amount that's happening in our communities around preventing people from ending up in hospital. But I just don't know we're quantifying that and really understanding all of that.
Thank you. Anybody else? No? Sarah, you want to come back?
No, just to say I obviously support everything that we speakers have said. And a big part of the community transformation, one of the key components is building healthier communities, which is very much linked to what we've just said and about how it's somebody's holistic well-being. It's not just about intervention in a clinical sense.
Remiss of me earlier, but I should have welcomed Sarah. Sarah's sitting in for Deb Atkinson today. So Deb is attending her son's graduation in Manchester. So I'm sure you would agree that she had a happy occasion there and hope she has a good time. Okay, welcome Sarah. Thank you. Okay, item 7 is reporting from committees, the escalation and assurance reports. Take those in order. Jim, you've got yourself first for the audit committee.
Thank you, Chairman. I'll just mention very briefly the 3 items highlighted as alerts. At our meeting, which preceded the extraordinary board meeting, we picked up on the external auditor's assessment of the organisation for the year. And one thing they specifically mentioned was that they thought we possibly adopted over-ambitious plans at the beginning of the year that were non-deliverable. We didn't quite agree with that comment, but we took it on board. And they're also saying that we need to make sure that the plans for this year are reasonable levels of risk. And we've done an awful lot of work within the ICB to make sure that that is the case. They are high risk, but they are deliverable. So that was an important comment that they made, and I believe we have taken it on board. We're developing a business case process, and we also recommended the data quality strategy that was brought to the meeting for approval by the board. So that's all I want to mention in respect of that.
Okay, thank you. Comments, questions on that one? Audit committee? Nope, nobody indicated. Okay, Sheena, quality committee.
Yes, thank you. So I would like to just take people through in a similar fashion to Jim, just to focus on the alerts from the quality committee meeting that took place on the 22nd of May. And you'll note that we've now moved to bi-monthly meetings of the quality committee, as was agreed in review of subcommittees. We have actually had quite a long debate about this within the committee. And what we've agreed to do is we do have some concerns about whether we'll be able to, it's a very, as people I'm sure are aware, the scope and range of what we do in the committee is really large, because we've got not only the statutory responsibilities of the ICB board in relation to sound, safeguarding and continuing healthcare, but also the oversight of the system about quality assurance. So we said that we would really review that in September, when we've done a few rounds of this, just to see whether we're able to get through the range and scope of the responsibilities of the quality committee and really give us sufficient time to be able to discuss the items that are there. The second alert I just wanted to bring to you is around one of our statutory functions, which is about learning disabilities and autism. And we did have a conversation around just this strategic move forward in relation to the right provision of people with learning disabilities, with the focus really being on ensuring that we enable people with learning disabilities to live the best lives that they can, and to get that balance between the sort of prevention, early intervention, but then when people have more complex needs, to be able to meet those effectively. That was particularly in relation to plans for particularly assessment and treatment beds going forward. We then went on to another area, which was around children and young people and our special education and needs. And it really was this absolute focus on understanding some of the very long waiting times we have, particularly for children with neurodevelopmental needs, and thinking about how do we look at this from both a short-term but also a long-term strategic view, and how we look at the whole pathway review to move towards look into a business case in the autumn. And we had a very good conversation this morning at our flows board, where we gave really sort of an in-depth brief to the whole board around what were the particular issues here, some of the ways forward, and I think really pleased that we continue to see this as an ICB as being a clear area of prioritisation moving forward. The other areas I just wanted to mention was around we reviewed the quality impact assessment process, and we noticed there's been a lot of progress made against this, but we still, like everything, still more to do, and that we will be looking at further training on this, and also taking a sort of a consistent approach through the support through a PMO function, or project management office function. And then just the final area I wanted to mention was around one of our subcommittees of the quality committees, the clinical effectiveness group, and the way that we get feedback from them is in a very similar fashion to what we're doing now, which is to look at AAA report. And we looked at from that, I just wanted to raise as an alert from that AAA report, the consideration of new medications for managing people with weight loss, and how this may be impacted in terms of how that gets used and the cost of using that in an appropriate way going forward. So we're going to be developing a system position and statement about clear plans regarding the prescribing of that through that clinical effectiveness group. So those were all the things I wanted to mention. Thank you, Roy.
Thank you, Sheena. Any comments, questions? Sheena's? Yes, David.
So I was in a meeting with Steve Powers, who's the National Medical Director, yesterday, and it seems that the national team will be picking up some of the challenges on the use of those weight loss drugs, because it is that obviously are very effective, but at the same time they're very expensive. We need to ensure we've got ways in which they can be delivered. So they are picking that up nationally and working with our colleagues from NICE.
Okay, thank you. Thank you for that information, David. Okay,
I was just really interested that you picked up the waiting times for children and young people with SEND. We do have tried together a model of low or no cost in Hyndburn, whereby just moving where the clinics happen for once a day, the waiting time for people to be assessed by a speech and language clinician has dropped to from over 40 weeks to 0. So there's a real opportunity for us to scale or spread that model across. It may not solve the entire problem, but certainly is in the waiting to be spread, which sounds like low or no cost. So I'm very happy to follow that up with Sheena.
Yeah. Okay, very good learning point. Thank you. Thank you, Sally. Okay. Anything else on Sheena's report? If not, we shall move back to you, Jim, for the finance report. There's 2 meetings, I think, on that. So
yeah, thank you, Chairman. There are 2 meetings, and interestingly, most of the items that are under alert are picked up during today's meeting. So, which is part of the role of the assurance committees to almost kind of to consider things in more detail before they reach the board.
Yeah.
Just to briefly mention a couple of things from the 6th of June meeting, we were told about how deficits would be recovered. And it's partly through a combination of withdrawing the capital allocation and partly by taking away revenue monies in future years. But the direct impact on us this year is that we will be losing £10 million from our capital allocation by virtue of the fact that we overspent last year. And that will come also in the capital report later on. In the July meeting, we highlighted the relatively low level of utilisation of virtual wards. In a later report, it suggested that we're aiming for an 80% utilisation. It was 52% in May, so there's a bit of scope there, and it's a relatively easy way to address some issues around capacity. So we really need to encourage the use of virtual wards. We noted that transforming current hospitals, particularly around the fragile service work, was going rather slowly. But again, we picked this up in our pre-meeting today, our earlier meeting today, and that is hopefully going to speed up shortly. And just to very briefly mention that the first item of advice talks about the 2024-25 savings target, which at the time of that meeting was £531 million for the system to save, which is a very substantial sum of money. So just to get your head around the kind of scale, our budget is around about 4.4 billion, I think it is. But collectively, the system's got to save £500 million this year.
Okay. Thank you for that reality check, Jude. And any comments, questions? Yes, Craig.
Thank you, Chair. Just to alert the board that we do have an improvement plan for virtual ward utilisation, and that's been refreshed on the back of the urgent and emergency care deployment of resources that I'll pick up under my paper. So Jim's absolutely right. It should be a focus, and it will be reported back to FNP on the progress of that improvement plan.
Okay, thank you. Anybody else? Jim, could I just bring you back to one of the advisors, which is the quality of the meetings that the board needs to approve on the 6th of June meeting?
Yep.
Yep. Happy to approve
Sorry,
that?
yes. We'd like the board to approve them. It's basically trying to make it consistent with other committees. So there's nothing kind of out of the ordinary about this, but it wasn't consistent. And by virtue of the fact that we had not a crisis position, but our permanent chair was taken away from us and stuck in front of this committee, basically. So we were one down. So it made membership a little bit harder to achieve the quorum. Hence the need to amend it, and that's the reason why we're looking to change the quorum arrangements.
Okay, thank you. Well, a couple of other items on there, but it's on the UEC report that's coming later. So thank you, Jim, for that. So we'll move us on to Debbie, I think, Primary Care Commissioning Committee.
Thanks, Chair. So there's 2 meetings for the Primary Care Commissioning Committee that we've offered a AAA against. There's no items of alert, so I'll just draw out a couple of items that came against advise or assure, particularly because some of them link through to today's agenda. So looking at the 1st of May meeting of the committee, we approved an initial apportionment of the capital budget that has oversight of within the committee. So that's been allocated and directed, and it's obviously relevant because we're looking at the bigger capital pot today to understand that there is something that contributes to primary care separately. And what we've said that we'll do is we were conscious there was a discussion today about the board budget and approach, and we're going to have a development session just to make sure that everything aligns moving forward and we make best use of the funding that's available. We also, under Assure, signed off the first NHSE annual assurance framework submission. So that had also been reviewed by Audit Committee really helpfully, just to give the board extra assurance that it was rigorous and it was accurate. But I'm pleased to report that everything was rated as being green and fully compliant and evident. So given it's an important return and the first one for those delegated budgets that have come to the committee for oversight, it's worth just drawing attention to that as well. In terms of the 13th of June meeting, we'll move on to the next page. Just one item to mention. So we had a look at the pharmacy access programme. We received an update against that and the different programmes of activity that are in place to support improved access to pharmacy services. So we had a good understanding of the capacity, the funding, and what the role of the committee could be to support making best use of that. And what we agreed in that meeting was that we'd refer a discussion through to the Patient Involvement Engagement Advisory Committee, because we felt that there was a lot of new services and improved access that perhaps didn't have the level of awareness that was making best use of it. So we thought it was worth having a look at that to be able to support and gather that feedback to ensure that it's rolled out and understood in communities so people can get to things when they're valued.
Okay, thank you, Debbie. Comments, questions? No, nothing. Nobody. Okay, thank you so much. Okay, we shall move us on to People Committee. Jane, yourself?
No, we haven't had a meeting with that.
Oh no, I see. Yeah, okay. So sorry, Debbie, we're back to you.
That's okay, that's
Public
okay.
engagement.
Speaking from Jane, guilty. So the Public Involvement Engagement Advisory Committee, we had a development workshop on the 25th of April. So a similar point to the one that Sheila made, that we're moving to less frequent meetings, and so what we were really conscious of was that we needed to look together at what the work programme would be to make sure that we can still get the right depth and discharge the responsibility that the board's given to us. We spent some time working through that and agreed some changes to be able to support that. The first meeting that we've had since then as a committee was on the 26th of June. So again, there's no items for alert, but there's a couple that's worth mentioning just to draw the board's attention to. So as part of that consideration of meeting less frequently, what we've done is we've set up a number of subgroups that would be able to do some of the legwork really and the thinking to support the formal committee and its responsibilities. So we've set up 2 new subgroups that are looking at reaching diverse communities and also engaging with audiences who are digitally excluded. So what we tend to find as a consistent theme through all the engagement and involvement that we do is people within the community constantly telling us that digital engagement's brilliant, but not everybody has a computer and not everybody's confident about using that, so we can't just use it as a channel. So we thought that that was worth a focused look at and some recommendations coming back to the committee from engagement and involvement. And the other group that's been set up is a new ICB consultation working group. So that group will also report into the ICB's programme board, and it will do the legwork and the thinking around those formal consultations that are needed around service change. So again, it's just giving us a little bit more capacity to be able to move through things at pace and at depth whilst retaining the oversight within the committee. The other items, just to quickly mention, public engagement and involvement under Assure. We've introduced a series of webinars to share expertise and best practice around engagement and involvement. So one of the things that committee members have found really valuable is, as well as regular reports about the engagement and involvement that the ICB is delivering, it also has a focus around place and also other sectors and key partners. So to support the focus remaining on that, we're going to introduce some webinars and we'll make sure that the ICB board members have got invites to be able to access those, so it brings to life again some of the activity that we've delivered or facilitated or we're aware of. And then finally, just to mention that we had a closer look at 2 pieces of work that are coming through today to board agenda. So the sequencing of the committee's agenda is working much better in that we're having an advanced sight of items ahead of them coming to board, so the committee can have a look at the engagement and involvement that happened and give assurance or feedback around any improvements. So we looked at the urgent and emergency care strategy and also shaping care together. So just to give you the assurance we are doing it ahead and we're able to offer feedback and add value to the board's work.
Thank you very much, Debbie. And again, are any comments or questions? Yes, Andrew.
Just to mention, when you're talking about digital access, just when you look at that, maybe consider the use of our community libraries, which do have ICT facilities available for the public, and also often there is technical support available. So please do look into that as well. Thank you.
Okay, Tracy.
Thank you. Yeah, I just want to say thank you, Debbie, for that detailed description, because I think it's really helpful to know about those 2 subcommittees, which I absolutely welcome, that focus on diverse communities and digital exclusion. I'm just wondering, the work of these committees, will it go back into the PIAC in terms of that sort of understanding what's coming out of these, or will it come to this board? Because I'd be really keen to understand more about what the strategies the PIAC are coming up with in terms of looking at these areas, because I think there's things happening at place that are doing similar things, particularly around things like not just digital exclusion, but also the kind of language that we use as a system. Something that came up at the place meeting on Monday in Blackpool was that there's people not attending for cervical smears because they simply just don't understand the letters that are being sent. So there's a wider kind of exclusion here as well, and I just wondered if some of that work could feed into that, because I think it's just so important that we understand how we're leaving people behind a little bit sometimes with some of the services. So yeah, it's just, I suppose, a plea from me that can we see some of the recommendations, I suppose, that are coming out of the PIAC and these two subcommittees?
Yeah, absolutely. So what we'll do is there'll be reports from the subcommittees that will go through to PIAC, and there'll be a discussion and a consideration. And what I'll make sure, Tracy, is that those key themes come out through the AAA, or if there's any other areas of focus, it can go into the best practice webinars and sessions. There is a really strong focus on place. That's one of the things that we were conscious of. So what we've done in the previous committee meetings that met more frequently was there was always a focus on place. So we're just looking at other ways of making sure that we capture that intelligence and learn from it. So we'll definitely do both. And I'll pick up the point that you've made around that specific feedback as well with the comms team. That's important. We don't lose it. It's coming through. Yeah, thank you.
Okay, thank you very much. Thanks to all the committee chairs for reporting back there. We've just got one more left to deal with, which is the Specialised Services Committee. Craig, just before you go into that report, Craig, just a question. Is there a non-executive director on that particular committee? I know that Jim. But I noted that the committee was chaired by the Assistant Chief Executive of Cheshire and Merseyside, not by a non-executive director. So, yeah. Okay. Carry on.
Do you want me to answer that?
Yeah, if you can, thank you.
Yes, so the intention is that a non-executive director chairs this.
Okay.
We've opted for that not to be Lancashire South Cumbria in year one, due to the fact we're going to be hosting the hub arrangements for the team, so we felt it would be better. I think there has been some challenges with the nominations from the other ICBs, hence the officer standing in. We are still in shadow form and there was no decision to be made, which is why it was an officer rather than a NED. For next time, though, there will be a change in that arrangement, Chair.
Okay, thank you.
So I wasn't at that committee, but obviously there's a report. If I'm happy to take any specific questions. The committee is still in its, as I said, formation, and whilst services have been delegated, a number of services from NHS England, the team still remains the responsibility of NHS England until April 2025, and we are still required to make transaction payments and work with the team on the commissioning and therefore the priorities, and we've established our own specialised commissioning oversight group that I currently chair and Jim has attended, and that will be to transact the business of Lancashire and South Cumbria's specialised commissioning in advance of the committee. So we'll obviously be managing a lot of that work in the engine room of the committee, and we will be bringing items here for update from the joint committee by exception in the future.
That's great, thank you. I'll bring in a mission. David, did you want to comment on the thrombectomy thing?
Can I just comment on the thrombectomy issue? So, if you have a stroke, most people who have a stroke have a clot that's got into their brain, and the way to manage that, if the patient is otherwise reasonably well, is to remove the clot, and you can do that mechanically. So this is called mechanical thrombectomy. And it can have it means that rapidly a patient can improve because you improve blood flow and the brain can go back to normal. So it's fantastic. The issue is being able to offer that service 24 hours a day, 7 days a week. And for Lancashire teaching hospitals, there's been a challenge around recruiting the workforce to do that, which has been ongoing for probably at least 2 years. They have got a number of consultants now working there, but the service is not provided 24/7. And as you can see from this report, a rapid quality review is to be undertaken, and this is an escalation of the risk, and which is being led by the regional specialist commissioning team. So that we can work with the other 2 providers of thrombectomy in the Northwest to look for solutions. So I just wanted to give that clarification.
Okay, thank you. I'll just ask if, Sheena, is it the same item or is it just something different? Something different. Is there anything specific on that particular comment that David's made? Or move it on?
Sorry, Chair, I had a couple of questions, but one of them was, so do we know when that rapid quality review is happening? Because the learning's quite key, isn't it, for us?
As far as I'm aware, it's going to be early September.
Anything else on that specific before I just ask Sheena wants to ask a question?
Yeah, I think we did discuss this, and I'm just trying to refresh my memory about it, around how we're going to look at the quality aspects of specialised commissioning, and what our responsibilities and accountabilities are of that ICB board.
Okay.
I think.
Great.
I think Sarah might.
Okay. Right.
Well, it was one of the comments I was going to make, and then I've got two other questions, if that's okay. So we've got the first report on SpecCom coming to Quality Committee next week, and the lead from the SpecCom team for quality is coming to committee as well. So, and the report has been done with more focus, obviously, on the services that are relevant to Lancashire and South Cumbria rather than the whole list of SpecCom services. So that report is coming next week, and we'll ask for a little bit longer to be spent on that item.
And I think we did. I mean, we'll just have to sort of suck it and see next week at Quality Committee, but it's just understanding how that's going to work and operate. So I think we'll bring that back, if that's okay, Roy.
Of course, yeah, absolutely. Okay, David, did you want to?
So, and in some respects, it's ensuring. I mean, specialist commissioning has worked as a regional team and now works to the 3 ICBs, and they now work to a board. And although they presumably worked the NHS in the board in the past, that's a long way away. And so we have had to work with them to understand how they would present data to the quality committees, but also Deb Atkinson has done a lot of work about how we can establish a consistent reporting of risks and how that can fit into the ICB risk register as well. It's a work that's in progress.
Okay, thank you.
Chair, sorry, can I just...
Of course, yeah.
So I just had another question, which you might not know the answer to, Craig. So we might be able to clarify next week in Quality Committee. And then I had one comment. So the question was around the termination of pregnancy, because it states in the report that they've halted the procurement. So I suppose my question was, are there any gaps because of the halt or the delay in that procurement in terms of a complex termination of pregnancy service? So that's my question. If you're not sure, we can probably pick it up at Quality Committee next week.
Not that we've been made aware of, but I will check. So just to make sure.
And then my comment, Chair, is just to, because I've seen advised that the Furwell inquiry that was commented on at that meeting, that's obviously the Countess of Chester, Lucy Letby inquiry, and it's commencing in September. And I suppose I think it's really important that even though that's not our system, the potential impact of that inquiry and some of the reporting on staff who work in those services across the whole country, but obviously of course Lancashire and South Cumbria could be quite huge. So it is really, really important that, as well as the SecComs, that we're just mindful of that as a system and we manage it. And there'll also be learning and exactly through CEDAW, which is the panel we have across the system for the overview of deaths and learning from child deaths. So it's just I know it's in there in the report, but I think it's quite important as a board, a bit like the COVID inquiry, that there could be big implications for the whole of the systems coming through the Furwell inquiry. So I think it's important we keep an eye on that inquiry and the learning that's coming out of it.
Okay, thank you. Anybody else? I do notice actually, David, that there's a risk indicated here for the thrombectomy service, and a contract performance notice been issued to LTH. That's going to be part of this rapid review, no doubt.
Yes, that's right. I mean, we've been, even before April, when we took over the commissioning of this service, we were aware of the concerns and have been working with Spec on this. Progress has been a bit slower than we thought, and I think the patient risk is such that we have put it on our risk register, and we have encouraged the specialist commissioners who hold it to actually issue a contract notice to use it. And in fact, the oversight we have with the trust, which takes place every month, where we meet with their executive team, this will be an item of discussion at this month's meeting.
Okay, that's helpful. Thank you so much. Craig, anything to add?
No, I suppose we'll just ensure that this is updated through the AAA that goes through our NED representative for the future. And we just need to get to that rhythm. I think as this was the first one, it's been slightly different than we would normally expect.
No, that's fine. Thank you. Thank you so much. Thanks everybody for those report backs. That was all the items on item 7. So we move to our business items. At item 8, we have the board assurance framework. Sarah.
Yeah, thank you, Chair. And I just wanted to really acknowledge the work of Deborah, who isn't here today, Sarah and Claire in the corporate governance team, because I hope board agree that I think the board assurance framework as it is now is vastly improved from when we first started work on the BAT, which is what you would hope and expect as a newly formed board. So just a couple of comments from me. I think what the paper is trying to present to board is the ongoing work that we've been doing collectively as a board since March, but also then the full review that the executive team have taken as well, and the realigning of the board assurance framework to kind of take key risks. Also, we've done some, I think, what's been really valuable work in the execs in terms of defining some key deliverables that sit under the strategic objectives, so that hopefully we get a bit more assurance and clarity around the work that's going on in the background to help us deliver on our strategic objectives. It's also, the paper is reminding us of our new risk management policy that we previously approved, and that the reporting on the BAF is going to realign to that now, so it will come here twice a year going forward. And we are doing ongoing work in the organisation to embed the risk management policy. The other thing that is flagged in the recommendations is the 2 operational risks that are currently standing at 20 on the operational risk register, and one of those is relating into quality oversight of primary care, particularly because of the capacity around that, but also to autism weight, in particular adult autism weight. So really we're just asking board to note the contents of the report and to provide any comments or feedback to myself. Thank you.
Okay. Nothing to approve there, Sarah.
No, it's just asking to note.
Okay.
Well, comments.
Okay. Okay. Comments, questions? Yeah, Debbie first. Yeah.
Thanks, Chair. So definitely welcome the report, and you can see the breadth of the work. And I think it's a very helpful and also broad but focused approach to risks, which will underpin board assurance. I've just got a question. It's probably an observation, and it's down to timing, but strategic SO3, which is page 62 of the pack, which is all around continued workforce challenges. And I noted that under gaps in assurances, there's quite a few references to gaps in assurance around primary care workforce data, and how challenging it is to gather that and it not being visible. And there's nothing under the mitigating actions to sort of recognise how that's being taken forward. So I know that there is going to be a conversation at People Board around primary care workforce. So it might just be that it's a timing issue. I just felt that given it was a gap and it was recognised but not actually anchored under actions, it's perhaps something we could be conscious of in the next update, that it's embedded and built in.
Okay. Before I come back to Sarah on that, is there anybody else on that, just on that particular issue? No, Sarah? Yeah.
Well, I think it's a really valid feedback, so we'll take it away and make sure we address that. I suspect it's probably a combination of People's Committee and our changeover around our CPO as well, but we will pick that up and make sure when we come back we address that.
Okay. Yes, Jim.
Thank you. Well, first of all, to endorse Sarah's comments, I think this is a much improved package of measures basically to implement the board assurance framework. So I think it's really very good. My specific comment is there is reference in there to something being approved by the Integrated Care Partnership Board. I'm just wondering, we don't see a lot of what's going on with the Integrated Care Partnership Board. Kevin mentioned it in his chief executive report. It gets mentioned in the NHS Joint Forward Plan as execution link with that in there. And I'm just wondering whether we should consider bringing the minutes just for information to this board, so we've got a better understanding of what's going on within the partnership, because there's a big overlap, and increasingly that system working is crucial to our success.
Thank you. Yeah. Chief, Craig first, then Chief Executive.
I was about to say we're doing a lot of work on the refresh of the Integrated Care Partnership with new chairing arrangements. and new partnership membership with the new set of priorities. There's been 2 workshops. Kevin and I have been to, I've definitely been to one, I know Kevin's been to 2. There is a proposal in the forward plan to bring a full update back to board on the integrated care partnership. But you point about the minutes. There are currently 4 formal boards a year, so I don't think there's any issue with the minutes being received here. But I think, as we've done previously, the board has asked for an update on the integrated care partnership, its business and delivery. So that's planned in for a future board meeting this year, Jim.
Okay. Any other comments on that before I ask Chief Executive to comment? No.
Don't add to what Craig has said, and in addition, there are some proposed changes to the terms of reference which have implications for us as well. So I think it does need. We'll take that on board, and I think we did have Michael Green, who was the former chair, attend this meeting some time ago. I think probably it would make sense with Damien, the new chair, to do that as well. So I think we'll take that away, Jim, and
Okay. Thank you. Thanks, everyone. No other comments on that then? No? Okay. So, that was the noting, Sarah? Yes. Yeah. Okay. Thank you so much. So, finance report month 2. Catherine, thank you.
Thanks, Chair. The paper sets out the collective position reported at the end of May 2024. As a system, we plan to be 54 million in deficit at the end of month 2, paying slightly better at £53 million deficit, mainly due to North West Ambulance Service reporting break-even rather than the small planned deficit they anticipated. As Jim has articulated, there was a significant challenge for the system this year in terms of delivering £531 million worth of efficiency savings. We've delivered 42 million of that at the end of month 2. And section 7 of the paper goes on to talk about the risk associated with delivering the remainder of that target. We've quantified it around about £180 million worth of risk associated with delivery of that target, very much linked to those red high-risk schemes that obviously Kevin will come on to talk about in the system recovery and transformation paper later on in the agenda. For month 2, we were actually monitored against our draft plan submission deficit of 198 million. When the final plan went in June, it confirmed achievement of the controlled total deficit position of 175 million. That would roll forward into our month 3 position reporting. And as we're aware, that will be cash and resource backed. However, another role of the Secretary of State has come into play is to approve the final NHS plan, at which point that cash and resource will be distributed through allocations to ICBs around about month 5.
Okay. Right. Okay. Thank you. Okay. Thank you, Catherine. Any questions from anybody on the finance report? Finance. Yes, Jim.
So just an observation, and I think we just need to be aware of it. We've more or less touched on it, but the savings plans are back-ended, significantly back-ended. That introduces obviously more risks than if they were kind of steady across the whole of the year. So I guess we are aware of it, we are monitoring it, but if there's any slippage, it almost becomes irrecoverable when it's all at the back end of the year. So just to be aware of the situation, and that adds risk to it, which in effect is partly why the external auditors have made the comments they did in respect of last year's financial sustainability assessment.
Yes, Jim, I agree with the comments you made there. I mean, certainly one of the trusts has a significant amount of backloading on its plan. And it was a concern. I think we did discuss that particular concern with the board, but suppose we'll have to look forward, and I suppose we'll discuss that in the transformation discussion, the R&T discussion shortly, Kevin, as well. Okay. Anything else on the finance? No? Okay. Catherine, we'll have to note that. That's noted. So back to you again on the joint capital resource use plan. Thank you.
Thanks, Chair. As per last year, it's a statutory requirement of the ICB to publish its joint capital resource plan, usually shortly after the start of the financial year, but what with the election and final planning timeframes, the requirement is to publish by the end of July. So this paper sets out how we will utilise the capital allocation across the system. It has been reduced by 10 million, as Jim pointed out earlier, as part of our control total acceptance as a system. So it just talked to a reduced capital envelope that has been agreed with partners across Lancs and South Cumbria. I think there's two main things that are included within the paper around business cases to support the Learning Disabilities and Autism facility with Lancashire Care Trust, and also the electronic patient record system with Blackpool Teaching and University Hospitals Morecambe Bay. Those are the two big business cases for which this capital allocation will support June 24-25. Other than that, there's nothing specific I wanted to draw out, but happy to take any questions. We do need to approve this today, so we can probably sign it.
Debbie.
Thanks, Chair. Thanks, Catherine. It's really helpful summary. I do support the approach and the assurance that you're giving around the prioritisation. And I think it's very wise to both allocate the board funding, but also the strategic investment reserve to give us some flexibility that we can work together with the provider collaborative to direct. It was a question. So on page 82, there's a comment about there being a number of primary care service development and efficiency developments currently paused because of affordability. And the end of that paragraph is there's a long-term and general shortage of investment into the primary care estate. So that sort of piqued my interest really, because it led me to then think, how is this funding being directed to primary care? Because it's at a global level, I couldn't see sort of whether it will actually be supporting it. So kind of my question is, if that's the challenge, beneath the figures in the finer grain, are we using some of the money to address that challenge, or am I just left with the worry that that's the position and we can't do anything about it?
There is some support to primary care, obviously not as much as anticipated, and I think that's a consistent trend across all of our schemes because of the reduction against the allocation we got initially. I think primary care is a very discrete, separate, almost programme for development. It's probably worth looking at it as a separate agenda because it's subject to a separate funding stream almost that's governed very differently to the capital allocation through NHS England. But I'll take your point away. I think it might be worth bringing something back around primary care capital investment.
Dave wants to comment.
So
yeah.
Issue with primary care, as Catherine said, there's not a great deal of capital. However, there is there's a couple of items that come forward. First of all, with the digitisation, we've actually created more room because we've taken all the paper records out. But the second thing is that there's now going to be a further expansion of medical student training and GP training over the next 5 years as well. GP training numbers will also rise. So we've started some early discussions with our ICB estates team to understand that, because it will be a significant impact on primary care and the capacity for them to have all of this extra people there. And that also is now being having further discussion with the regional team, because I think there will need to be a national policy.
Okay. Anybody else want to go in on that? No. Julie's shaking her head. Okay. Okay. All right. Okay. Thank you very much. Anybody else then on the joint capital resource use one? No. As Catherine indicated earlier, we need to approve that. Colleagues, are we happy to approve that as a board? Yes. That's agreed. Yes. Thank you so much. Okay. Karen, on to the system recovery and transformation.
Okay, just briefly, we do have a risk assurance process that runs monthly with each of the trusts to go through progress against the SIPs, and generally that's working very well now. There are some red areas which are shown in the attached tables, and Jim is right. Those plans are generally back-ended, about 70% of the savings in the final 6 months of the year. That's what we had last year as well, and we do keep a very close eye on that. Probably worth noting that the most significant risk around the trust is Blackpool, which is also the most back-ended of the plan. So it is worth noting that. I think Jim's point is well made. We do make mention of a few big areas of system transformation which are being progressed. Probably the The biggest area is urgent and emergency care. We do have a report on that separately here. I think we have got some really good data now and some tailored plans around each hospital, which looks at the primary care element and the social care element, as well as what's happening in the hospital in some granular detail. I do think it's important that formally this board looks at that. So our intention is to bring a report to our September committee to update our commissioning intentions in that space. And we'll probably do that in a few other areas, particularly we make note again of the acute service configuration. Effectively, there are a number of clinical areas that have been identified, which are either fragile or capable of some streamlining and running as a network across the system rather than simply operating them separately in splendid isolation from each other. So they would probably be the first area, but we also have a piece of work which is looking at the whole of the clinical reconfiguration program for our system. And that probably won't be surprised if we're able to bring a report in September, but I think it will be something we bring to the board this side of Christmas. And again, I think formally the board will need to agree that we probably need to do a part 2 or a development session beforehand, because it's a very significant issue for us. So yes, there is a fair bit of risk. I'm comfortable with the risk processes we have in place are comprehensive and thorough, and they have matured quite well now. And probably the biggest risks are around those big corporate programs, urgent emergency care, and the acute reconfiguration. Happy to answer any questions.
Thank you, Kevin. I was just noting in the conclusion there that in terms of governance and reporting arrangements in place to oversee the delivery of some of this plan. Tracy, I know you're the chair of Blackpool Place. I'm sure you'd be happy to bring some report back maybe about how that's working within that certain area. I'm just wondering if it's worth considering, Kevin, if we do ask some of the place directors maybe or individually to come or together to this board to give us a report on how that is working within the particular places that they are involved in.
Very happy to do that. They do participate in that monthly process anyway, and so they play a full part in that. And one of the things we've been working through with the place directors is to make sure that within their own work programs for place, they're directly contributing to the recovery and transformation program. So very high priorities for the place directors are looking at, with the system in their areas, all the things that can be done to push admission avoidance and effective discharge from the hospital system. So very happy to do that.
Okay, thank you. I'll open it up then for comments on questions, discussion. Buddy? No? All very compliant today. Okay. Right, it's just for noting then. Thank you for the report. Thank you, Kevin. Okay, so move us along then. I said compliant, we're on integrated performance. I see, Mitch, you're on. Thank you.
Well, thank you, Chairman. There's a number of areas we will be compliant on.
I'm sure.
So I think just to remind the board, the metrics contained in this performance report are reported and discussed in different forums across the provider organisations and within the structures of the Integrated Care Board. And in large parts, it covers the NHS oversight framework metrics. The report contains data in the main for April and May 2024, so covering the first part of the new financial year. We saw last year to be unprecedented with the industrial action, winter pressures and the challenges facing our services. And early reporting into this financial year shows there's no let-up on the challenges and the demands facing our services. But within this challenging environment, the dedication from our frontline staff, the compassion and the hard work, I think is commendable in terms of how they care for our population. So I will take the report as read, and I will sort of cover the key headline metrics as stipulated by NHS England's operational planning guidance. So starting with urgent and emergency care, the average category 2 response times continue to be achieved for May 2024, with our performance across the North West Ambulance Service seeing a further improvement to 21 minutes and 42 seconds, which continues to compare favourably with the national achievement. Just to remind the board, the category 2 refers to ambulance response times for emergency calls, so stroke patients will fall into this category. As requested by the chair at the previous board meeting, we have also included in the Appendix A a summary of number of ambulance service indicators that are monitored. And if useful, we can include this in future reports as well. But the indicators primarily focus on hospital admission avoidance and diversion to more appropriate care settings. And in summary, we saw a positive improvement in these areas. So things like A and treat, C and treat, a number of patients conveyed to a non-A&E setting, they were all improving. Saying that, we did see an increase of 7,476 attendances, which is 10.3% increase in attendances in May compared to April. So there are significant pressures. However, performance against the 4-hour target in May was 77.86%, so above target, an improvement on the previous month. And for context, not for comfort, the LSC ICB footprint performs better than the national and the Northwest averages, and with the third best performing across the country. And more recent data suggests for June that is improving further. So moving on to elective care. So at the end of May 2024, we had 242,285 patients waiting for treatment. And again, just to remind the board, just for context, before the pandemic, this was approximately 120,000. So it's double the number of people waiting. And before the pandemic, there were very few people waiting above 18 weeks. Nationally, we might have seen in the media, the waiting lists are increasing. So over the last 12 months, 7.63 million people are on the waiting list nationally. And regionally, the Northwest also saw a small increase of 0.17%. In Lancashire and South Cumbria, we did see a significant increase compared to the national position. So over the last 12 months, our waiting list increased by 8.07%, which was an increase of over 18,000 patients on our waiting list. But in contrast, over the last 6 months, we have seen these waiting lists falling. As reported previously, all providers continue to work towards eliminating the 78+ week waiters, but pressures in orthodontics and gynecology put these at risk, and these are covered as part of some of the conversation we've had around our fragile services. And for a complete picture on waiting lists, I also want to draw attention to our community services waiting list, so that's also in the report. So the waiting list for adult community services fell further in April 2024, with 9.8% of adults waiting more than 18 weeks. For children's services, and Sakti's covered some of this already previously, so we have 470 children waiting 52 weeks, mainly due to speech and language therapy, but we are seeing different models of delivery. And as Sakti has mentioned, in parts of Lancashire and South Cumbria, particularly in East Lancashire, we have seen new ways of delivery that focuses on easy access, family support and early identification. That has seen a significant reduction on the speech and language therapy waiting list for our children. And this model is now being applied to other parts of Lancashire and South Cumbria. In cancer, we see a varied position across the 3 cancer standards. Once again, we met the 28-day faster diagnosis standard. Blackpool Teaching Hospital and University Hospital Morecambe Bay both met the 31-day decision to treat standard. However, none of our providers met the 62-day referral to treat target. And this is an important standard because this is about cancer begin on the diagnosis of cancer. The person beginning treatment within 2 months of an urgent referral. So that's an area we have not met the standard for a number of months. Finally, I just want to bring attention to the board around some of the metrics around primary care. And we have been reporting throughout the year that the volume of general practice appointments per head of weighted population is well below national averages. And at the place level, there are further variations. So nationally, there were 4,908 GP appointments per 10,000 weighted population. And in April 2024, with Blackburn, Darwen and Blackpool, had significantly less appointments at 3,560 and 3,609. And there's a clear link between this and the GP workforce that we have, which again is significantly less compared to the national average, and again significantly less in some of our places. So before concluding, just want to mention again that we are also introducing reporting on inequalities and looking at inequalities. And on an annual basis, as part of our response to the NHS England statement on inequalities reporting, we will be producing an annual report that will be going on our website. And this report will look at metrics such as waiting list by deprivation, by ethnicity, and also mental health access, recovery and access, and also flu vaccination split by deprivation, ethnicity, age and gender. And the performance report also looks at the flu vaccination. And this is important. And I think it's a good time to look at this as we reflect on the 23-24 flu campaign. And just to remind everyone, risk of serious illness from flu and consequent hospitalization is higher amongst those aged 65 and above. And what we saw with our flu vaccination program, 77.52% of people over 65 years and older were vaccinated. But when we explore the data in more detail, there are significant inequalities, especially when we look at vaccination in deprived neighborhoods and in people from Asian or South Asian heritage. In some respect, they are half of that of the general population. So there is a lot more work to do and plan for this as we plan for our future vaccination programs. In the interest of time, I will pause there. Happy to take any questions with support from my executive colleagues in respect of their portfolios. Thank you.
Okay, thank you. I'll bring people in a moment. And you alluded there in your comments to the ambulance performance report. So I've seen, and I think colleagues will know that we're the lead commissioner for NWAS. And I think it might be worthwhile perhaps considering Asim and board if we invite Darren, the chief executive of NWAS, to a meeting just to give us a bit of an outline, perhaps answer any questions that we may have in regard to that. It's an important issue, I think, that we've taken on. Blackpool were originally the host for that, for the commissioning of the ambulance service, Blackpool CCG, and we've taken over that. So I think it's important that perhaps we hear from NWAS at some stage. I'll bring other people in now, indicated Debbie and then David.
Thanks, Chair. Thanks, Asim. Really helpful summary, and definitely welcome the report and the focus that's in the report. So what you're able to offer us is sort of a breadth and also a depth, which is really welcome and essential in terms of assurance. And I suppose one of the examples which shows that the report's working for me is that in your cover report, you give us an update and draw out for our attention palliative care, which is domain 8. And you sort of rightly just make us aware that the number of people who've died without a form of care planning is almost half where we would hope it to be. So we're falling significantly short overall as an average, but there's also very significant variation as well in particular districts. So firstly, thank you for drawing that to our attention. It's important that we can rely on you to be able to get under the skin of those statistics and draw out for us areas that you might suggest we have a particular focus against. I'm just wondering for that one, because palliative care isn't within any of the key performance indicators, it's hard for board then to see how that will be made better or to have an oversight of it. So I'm wondering if it's something that maybe Finance and Performance Committee could receive an update against and then just close off on behalf of the board. I'm just conscious of how important palliative care is. It's one of the most vulnerable times, isn't it, for individual patients and families, and you've quite rightly raised that we're falling short of where we would want to be. So I'd really welcome a chance just to close that off really and get assurance of the progress that we're making against it.
Yeah, and it's something we have started to include in the integrated performance report that goes to the committee. It probably needs a bit of focused time to understand some of the issues and variations. So I completely get that, and I'm looking at that.
Brilliant, thank you.
David, I'll bring you in a moment. Is this the same issue, David?
It is.
Okay.
So, end of life care is really, really important. It really is. And the problem is that we end up with patients in the wrong place. And many of us would prefer to be at home or as close to home as possible rather than to be in the hospital. The ICB end of life care team recently won a national award because they've done a lot of work working with across the whole system, but how can we move to outstanding? And so that it's almost kind of how can we plan to move to that position? It may take us a number of years, but they have been doing that work, and it may be something that could come to one of the committees to help them understand the progress that's being made, because it's a really important key issue for us.
Thank you. Okay. David, yourself.
Thank you. So thanks for the report. Just two questions from me. So when you talk about urgent emergency care, you talk about the waits, and obviously we've got people waiting longer than 12 hours. And in a previous meeting, we heard an alarming amount of hours that people were waiting. So I think we had about 152-hour wait. So the report doesn't really give a sense of how long people are waiting, and I wonder whether or not you have any of that detail or whether you can provide some. But some people wait longer than 12 hours. How long are they waiting, and how many of those people are waiting very long periods of time would be my question.
We do have that, and I don't know whether they something you might be picking up in the next agenda item.
I don't have all of the
we have the details around that, not to hand.
So I will pick up because part of the ambition for this year is to reduce the proportion of waits over 12 hours in NNA. So it is something that we're now monitoring, but we've put in additional triggers for those who go beyond 72 hours now, and that has executive estimation and management for intervention following those long waits. So there has been action taken. I couldn't tell you to date how many exceed 12 hours and what the range is, but it is something that we are going to be reporting on as a part of this new ambition.
Great, helpful. And my second question is, you talk in the out of area beds for learning disability and autism, you talk about the pressures of ward closures. Now, I'm presuming that's out of area ward closures, but could you give a little bit more information on that if possible?
I can pick this up, Chair. This was due to a fire in one of our inpatient wards that required closing and couldn't be reopened until the fire brigade given permission. So it wasn't actually out of the ways, it was local, yeah. And due to the nature of the fire and the incident, it also impacted on the staffing resource. So when it was open, it wasn't open closed.
Yeah, thank you. Helpful.
Okay. So I've got a number of people who've indicated. So Sati, if you could just make a note of some of those questions or comments and perhaps come back to them in a moment or two. So I've got Jim first, Tracy, Sati and Sheena in that order, please. Thank you.
Okay, mine is just a couple of observations. And the first one is that I think the reporting itself is getting better and it's getting more pointed and more the way we wanted it. So, well done to Asim and the team. And I know there's further work to do in it, but it's starting to give us the information we need to see. And the second thing is that a lot of the detailed questions that have been asked around it are the sort of things we are asking in detail in the Finance and Performance Committee meeting. And we're getting increasingly assured by the answers we're getting. And we're increasingly assured by the amount of work that we're seeing being done within the ICB teams and also outside cloud providers as well in terms of delivering this. Because I think generally it is broadly going in the right direction at the moment, which is encouraging, I've got to say. So within Finance and Performance, we're able to step back and take a more of a objective assessment of what's happening now, which is a really positive position for us to be able to take. I think the board can similarly feel that we don't necessarily have to go into a lot of detail. We do need to understand where there are problems and challenges, obviously, but you can rely on this data much more than perhaps we could have done 6 or 9, 12 months ago or whatever, because I think it is presenting a picture which is, as I say, going in the right direction, basically.
Okay, thank you, Jim. Basically.
Thank you, Chair. Yes, to echo Debbie and Jim, really welcome report. I particularly welcome your verbal summary as well, Asim. Thank you for that. I think looking at the kind of cross-cutting things around inequalities will absolutely help us understand where some of those actions can be taken. I suppose what I just want to draw to the board's attention is obviously the human element of this, because whilst we've got people on waiting lists, people's health is deteriorating, but also just picking up some of the things around the other kind of context of this as well, because what we've also seen is while people are waiting, people are opting out of work, and we've got, you know, a real issue across Central and South Cumbria with people leaving work at an age where you would really expect people to continue working, and obviously that's having a detrimental effect on the local economy. And I suppose it's really just thinking about all of those solutions in the round, really. And as you look at the inequalities data, can we also look at finding out a little bit more about the people at the end of these waiting lists, so that we understand how many people are having to give up work because they're waiting, and is there things that we can do around keeping them well, around waiting well, around working with that wider agenda. We've got the work and health coaches investment through Workwell coming into our ITB area. I just think there's opportunities there that you know, as we improve the picture and get these waiting lists down, let's look at all the other interventions that exist and how we can again use that investment more productively, I suppose.
Okay, thank you, Tracy.
Very quickly, just to bring board's attention to, there's a pattern here when we started learning from, people don't necessarily understand what's in the letters, and the breast, bowel, cervical cancer screenings actually going down. We're seeing stage 1 and stage 2, which are earlier stages of detection, actually not really performing. We're not really doing well in detecting early. And then the people that are waiting for treatment has increased. So that it just paints a picture on how well we care for our cancer needs in the area. And the directors of public health have already agreed that as a priority along with ICB colleagues. So the board might want to consider just putting all that together as what is the picture that is painting when it comes to cancer care, which there's a risk, especially when the screening programs don't really work very well. We are all starting with a wrong foot because we're not detecting cancers early, and therefore that's leading to problems that are really a vicious circle. Just wanted to draw that attention.
Okay, no, that's helpful. Thank you, Sakti. Gina.
Yeah, I was just looping back to the point that David was making around corridor care, and just that we are looking at that within the quality committee about assurance about both that reducing, which obviously, as Craig said, is a key priority for this year, but also understanding that the application of the standards of care bundles with people are unfortunately in quality care. So I just wanted to just say that that's something that we'll be looking at again at quality committee.
Okay, thank you, Sheena. David. Yes, Dave.
Back to Sakti's point about our early diagnosis of cancer, and we are truly, we struggle, and we have been at that bottom of the list when it comes around to ICBs, and that's partly due to the deprivation that exists within amongst our communities. And there's been a lot of good work around early diagnosis of lung cancer, which we are a pilot because we have most deprived populations. But one challenge is that the commissioning of screening services continues to sit with our friends in the regional team. And that is a challenge. As to connect up, for example, bowel screening and other screening programs, it'd be really helpful if it was within our remit, and then we could do something different.
I do recall, David, some time ago now, when it was at CCG, that Black Bloods and Black lung health checks, which did make a had a good effect. So, yeah,
Yes, and it's still running.
Still running, absolutely. Thank you. Okay, nobody else indicated. Want to come back?
Yeah, I think that's quite a lot of good comments there and good thoughts there. And I think my reflection is, I think what we focus on is sometimes the numbers and the percentages. I think, Tracy, your point is there's somebody behind these numbers and what actually means for them. My reflection, and sort of attending with SACTI, the health and well-being board, is I think there's probably a rethink required on how we use the entirety of our structures, where we've got the right people around the room, because some of the solutions are not necessarily just within the NHS, or many of the solutions not within the NHS. So cervical screening, breast cancer screening is something that is within the integrated performance report, but it's at place level and there's variation at place. So it's about how we use the entirety of the structure that we have health and wellbeing board place partnership to have some of these conversations. And that's some of my thought process working with colleagues like SACTI on how we actually introduce some of these performance metrics in their meetings. So I think we could have a more of a richer conversation in different forums.
Oh, thank you very much, Steve. As you say, there were some very positive comments there coming from colleagues around the room. So thanks very much for your contribution to that discussion. Okay, I shall move along then to the urgent emergency care recovery and winter update. That's yourself, Craig.
Yes, thank you, Chair. So this is an update requested by the board as a look back from our achievements from 23 into 24 and delivery against the performance and the national ambitions. But I've also included within this our urgent emergency care capacity funding and also an update in relation to the Type 10 high impact interventions. I've put some of this in an appendix just for ease, so it didn't interfere with the flow of the paper. But I'm happy to answer any questions on the paper or any of the particular detail that's contained in the appendices. So Asim's already given an update, which is an improved position for April onwards. But for last year, we did deliver the 76% performance for our standard target. So we were one of only 16 systems across the 42 ICB to do this. This was also in the context of 13% growth from the previous year. Equally, you've heard that our ambulance times now have improved. We did meet our ambulance standard, which was 30 minutes last year, sorry, we were 26 minutes and 11 seconds. So we were one of 11 ambulance trusts to achieve that. This is all in the context of a very challenging urgent care system. And I don't want to take comfort in the fact that we're reaching 76% or we're doing our ambulance turnaround in under 30 minutes. The reality is that, as Kevin alluded to earlier, this is one of our biggest challenges as a system. We often have people in A&E who wait more than 12 hours. We have seen a significant increase, double-figure percentage increase in attendances at A&E. We've got a significant number of delayed discharges, and therefore that's affecting our flow. And as we know, we have, and Sheena's alluded to this, we have people waiting either in corridors or what we call boarding, where there's an extra bed put onto a ward. That is something we've committed to in our commission intentions to have a zero tolerance for and to work on improvement plans for. And that is what we're doing with each of our providers and places. So whilst we might be achieving some of that ambition, I want to put it in the context of a very challenging position. As we know, that will affect patient experience, therefore the quality of care, requiring us to staff more wards and more beds also comes at a cost as well. And we've just got to be mindful that the performance doesn't always equate to what's happening on the ground in services. So I just wanted the board to be clear, whilst it is a positive position in some respects, there's still lots of work to do. So I think that's important to note. In relation to our operational priorities and guidance, we've got a new target of 78% for patients to be seen in 4 hours from this year, and in the main we are on target to deliver that, and our ambulance target has remained as 30 minutes. But picking up David's point earlier, they've now asked us to start monitoring the proportion of waits over 12 hours, so that's something that we will see featuring in our updates here. In addition to achieving the national objectives, NHS England has asked us to ensure that we maintain the capacity within the system that we had in 23-24. We increase productivity, and we also continue to develop the services that shift our services from acute hospital services to more community or home-based services. They are our priorities for us, and we will continue to deliver against them. In relation to the urgent emergency care capacity funding, 40 million recurrent funding overall. This is for lots of people have a focus on the 40 million. I just want to put that into context. There are hundreds of millions of pounds spent on urgent care across our providers. This 40 million is one small element that we get additional for particular schemes to help with pressures. But we want to look at things globally with the totality of resource. But in relation to that 40 million, 9 schemes were supported utilising 28 £1 million of that investment. Those schemes include discharge to assess, home first, community beds, minor treatment centres, same day emergency, etc. So you can see we're trying to look at that focus from a community and out of hospital perspective. The remaining 11 million looked at supporting extensions of services to transition to safely manage new arrangements. It is important, I think, to note that the system pressures are the system pressures with regards to not just being the responsibility of a provider for the management, for example, the front door in A&E or the back door from a discharge perspective. There's a primary care component to this, there's a social care component to this, and there's an individual person component to this that we must not forget as well. So the schemes that we've commissioned look to support all of that, and I think hopefully the voluntary sector members who are here today will see that we did a top slice to support the schemes to allow the voluntary sector to provide some of that wraparound support, and I think that's the first time we've done that, and it was very, very well received. In addition, there's been an extra 150 million nationally of capital that says if you achieve the target of 4-hour waiting, this is something you can bid towards. So I think that's something for our providers to consider, and we've got a process to manage that within the ICB. Finally, under Section 6, I include an update on the recovery against the 10 high-impact interventions. Progression has been made against some of these. Some have not progressed as much as others, but in Appendix C, you'll see where we have got that progress and the overall maturity status. But again, I know we've debated here, this is a national requirement, and we are required to report against that. But it's worth highlighting that the acute respiratory infection hubs are due to be implemented this year. I know it's been something that previous non-executive directors have asked before, and we're also going to be looking at establishing a system-wide programme for a single point of access and improving our access to immediate care as part of the Transforming Community Services programme that SERV is leading on. So happy to pause there and take any comments or questions.
Thank you, Craig, very much. Before I bring people in, I'd just like to comment on one part of that particular report on the capacity investment funding. I'm sure the board would join with me in agreeing and supporting the money that is coming to 19 schemes of £21 million to support those schemes. Examples of there which are indicated at 4.8. Very much welcome that, Craig, and I think, as I say, I'm sure the board will join me in supporting and agreeing with that particular item. Thank you. So I'll open it up. Sarah first.
Yeah, I suppose it's a further comment on some of the discussion that's happened through the meeting on quality side of this, and you know, and Craig's obviously in his presentation recognised, because I think it would be good on a future update to have a more robust section on the quality, but we've covered it. But I suppose the challenge here is So, you know, a long wait is not good either. That's not a good experience and it's poor quality. But it's all of this is about juggling risk. And we know we've had some high profile cases of harm in the system over the last year, things that have been in the news, been on the in the paper. And we know through Quality Committee that we have got some evidence of harm in these pathways. And we've had Reg 28 from coroners who have served us with a flag on it. So, and I suppose the concern is, will the drive of a bigger target from 76% to 78%, what will be the impact of that on patient safety? And I think it's something that we do already keep a close eye on at the Quality Committee, but I think also the board, given this is such an area of challenge for us over the next 12 months, both from a system recovery point of view, financially, but that it's really the art of this is achieving everything we know we've got to achieve on these pathways without an impact on basic experience and safety of patients. And that's the bit that is, and, you know, all credit to the frontline teams that juggle this in day out and day out, because this, you know, these are some of our most pressurized areas where they're having to juggle and make really, really difficult in the moment decisions about how they manage the demand that's coming through and try and maintain all of that. But I think the points that have been flagged about quality, it's really, really important with the drive we've got on this over the next year. The ultimate aim is nobody in the corridors, but while we're achieving that, it's how we manage the flows through our A&E departments and into our hospitals that we're actually protecting and maintaining safety. And we know we've got challenges, not just in Lancashire, Cumbria, national. This has been reported on.
Okay. Thank you, Sarah. David Blacklock.
Just 2 comments, really. So thank you for the report. It's to read. I was struck by when we're talking about the boarding and corridor care, you know, it's an issue that I worry about a great deal, as the experience of people at that point is just absolutely horrendous. But we also hear about just how dreadful it is for staff. So when you're having to carry the risk of looking after somebody in the corridor, the stress and the pressure that adds onto our staff, I thought that was important to note. With the future, you know, there's another agenda item today, isn't there, about staffing and experience of staff. So the report feeling pretty hopeless about having to do that. And the second comment was just about it just is really perverse, isn't it, that if we hit the 4-hour target, we get further investment, or you can apply for more capital. I mean, it shouldn't go unnoted that just feels entirely the wrong way around to me. I don't know about you, but you know, when you hear about A&E departments handling double the number of people that they were designed for, and you can't, unless you hit your target, you can't apply for the cap. I mean, it just feels wrong. So I wanted to just note that really.
It's a really important point, David. Thank you. And we heard yesterday in a meeting, myself and Chief Executive at one of the acute trusts, their patients are up something like 200 people extra every day since last year. It's just a huge amount of extra pressure within the system. Okay, Tracy.
Thanks, Craig. Yeah, thanks, Craig. A really good report, really, really thorough. I think for me, it's going back to the point that Asim made, and the fact you drew this out as well, that the solutions to this exist outside of the hospital walls, and that we're looking more at investment in the community. And absolutely, you know, the work that we're doing as a sector to be able to use that investment and be able to demonstrate the impact of that is something I'm really keen to, you know, make sure that we can have some really good data that tells us what works there. You mentioned, and I'm sorry if it is in your report, but I couldn't see it, the hubs, the respiratory infection hubs. Are these physical hubs, and where are they?
So it is in the report.
Thought it might be.
I don't know what page that.
Sorry, I put you on the spot. It's okay, I'll find it, Craig. If it's in there, then.
Yeah.
It's page 123, 4.8.
Thank you very much.
The schemes that are referred to.
So are they physical hubs then, Craig, or?
So there is no requirement for a physical hub, but because of some of the existing arrangements our providers got some of those will be in a physical place for people to attend. Some are virtual. They've done it so there's a degree of flexibility depending on whether you want this to be a part of the virtual care offer, and indeed complemented by virtual wards, or whether if you've already got a hub established, which some of our providers have for other conditions, whether this could be included. So I can send some information outside of the meeting if that'd be helpful.
I suppose what I'm asking is what's the situation in Blackpool, because we're doing work around respiratory them. So yeah, I'll pick that up with you if it's okay.
Yeah, that'd be great.
Thank you. It's great. Thank you so much. Anybody else? Nope. Okay. Thank you. Thanks again, Craig. Appreciated. That's for noting. So we're on to you again, Craig and Fred. It's on the joint forward plan refresh.
Yes. So thank you. Board members will recall that we have already signed off our 5-year joint forward plan. However, there's a requirement when we complete a year to obviously ensure that this remains a 5-year forward plan, and therefore after discussions we agreed that we would refresh this plan to incorporate a new 5th year, but also to address some of the areas that were discussed in the intervening period from the sign off until this refresh. Refresh was due for March, but due to PERDA and the general election and delayed operational guidance, we were allowed and permitted some additional time. So the joint forward plan has been hyperlinked. Hopefully people have had an opportunity to read this. In the refresh, which is different from a rewrite, as I explained, we wanted to include information on implementation during 23-24, reflect the changes in direction of a new 5th year, as I've already stated, and update the plan to include reference number of developing system initiatives. So we took the opportunity here to include our recovery and transformation programme, the new hospital programme, which is obviously something we're looking at up to 2035, the development of the system medium-term financial plan, including our workforce strategy, digital and data strategy, and infrastructure strategy, and then obviously the development of the place-based partnerships and the local work programmes. So hopefully you'll all agree they add value to the plan and will support that refresh. In relation to the guidance from NHS England, as I said, this was only published late, but there was an expectation that all of the plans were either refreshed. A rewrite requires us to go back through governance. As you know, this is governed as well by the Integrated Care Partnership and Health and Wellbeing Boards. It might be something, Chair, that we want the board to consider with the partnership for the next iteration on whether or not the plan does require a rewrite or whether we can just do further iterations on a refresh basis. So there shouldn't be any huge surprises regarding the changes. It's not materially changed the document. We have done some restructuring to explain the quadruple aim related to the ICB strategic objectives, of which there are 6, and the 5 strategic priorities that drive and deliver those strategic objectives. So they've been explained, hopefully, in a more easy to read format that's also visual and diagrammatical at the beginning of the document to show the interconnection and the interface. That's something that the executive have worked on. So happy to take any comments or questions. Just a thank you to Carl Ashford, who's in the audience, and the team who've held the pen on this. This is not an easy thing to draft and write with all the comments. So I do thank Carl and the team for all of the heavy lifting on this, because I get the easy job of just presenting the final article. So it would be remiss of me not to thank them.
And Sonia, of course.
Yes. Thank you.
Thank you. No, thank you, Craig. Yes, on the rewrite of the plan, perhaps we should do a re-consultation exercise with our partners. Yeah, to ask that, take that away. Yeah. Okay. Anybody want to comment on that? No. All right. Good. Right. Thank you. Okay. Excellent. Thank you very much for that, Craig. Okay, and that is for approving. Actually, I have it on my agenda. Yeah, we have to approve. Yes. Yeah. Okay. Good. Thank you so much. So, Sarah, we're back to Shaping Care Together. Case to change. Yeah.
Thank you, Chair. So, Shaping Care Together is it's a health and care transformation programme that's been running for quite a number of years now, pre the ICB. It was previously led by West Lancashire CCG along with Southport, the Formby CCGs and the NHS organisations at that part of Cheshire and Mersey and within West Lancashire. It was then paused during COVID, and has also been paused a little bit. And as you know, as a board, because you approved the transaction, there was a significant transaction of what used to be Southport and Ulster NHS Trust and St Helens and Knowsley NHS Trust, and they've now been formed into Mersey and West Lancashire NHS Trust. Now that transaction is complete, they've reinvigorated Shaping Care Together because of some of the challenges around that part of the patch for Southport and for West Lancashire, and trying to make sure that services are being provided in the best possible way for the populations around there. And it's been agreed that the initial focus would be on urgent and emergency care. And actually, it's in a way, it's very pertinent this coming here today, because the challenges around for Cheshire and Mersey around urgent emergency care are very similar to the challenges we have, which we've discussed at length throughout the board today. So what we're asking the board to do, they want to go out and consult on urgent emergency care pathways and the provision of services across that area. The responsible partners are Mersey and West Lancs Trust, ourselves as an ICB, and Cheshire and Mersey ICB. And what you've got in your packs today, or the link to in your packs, is a pre-consultation business case. This is an evidence-based, it's a case for change, you've got the case for change in your pack. And from that, they want to go out and consult on that. So the case for change isn't suggesting any specific changes to services. It's presenting the evidence base for why there needs to be a review of urgent and emergency care pathways around those populations. And the obviously pertinent population for us is the population of West Lancashire, and that's why we're involved as an ICB. Even though more of the services and Mersey and West Lancs Trust is part of the provider collaborative in Cheshire and Mersey ICB. So the case for change really is a document that they want to go out and use to consult with the public on their experience at the moment of urgent and emergency care pathways. So for us, it will be consulting with the West Lancashire population and getting their views on what currently works well, what doesn't work well, and what they think of services currently around urgent emergency care, and any ideas or thoughts they have about changes or how that could be different. That engagement will then be used to develop a pre-consultation business case if there needs to be any significant service changes around urgent and emergency care pathways. Obviously, as well, the other complication with this piece of work is the fact that it's two ICBs as commissioners. So the paper is also, we are suggesting that establishing a joint committee might be the best way to manage this going forward, rather than any proposals having to come through three separate boards, because it would have to go through the Trust Board, our board, and Cheshire and Mersey Integrated Care Board. So a little bit like presentation we've had today on Spec Common, there's a joint committee of the relevant partners around specialised commissioning services. We can establish a joint commissioning committee which would bring together ourselves, Cheshire and Merseyside ICB, and Mersey and West Lancs Trust. I'm sure we've representatives from NHS England sat on it as we have to make the decisions. So really what we're looking for today, board, is an approval of the case for change so that we can go out and start consulting with the public, and to support for an establishment of a joint committee. If you support the idea or the concept of establishing a joint committee, Deborah would be working on that with the governance leads from the other two organisations, and we would bring the proposed terms of reference back to board for approval in September. So we wouldn't go ahead and just establish that joint committee without the board having the opportunity to comment on the terms of reference and formally approve those. So I'll put on, I suppose, last thing I would say is I have obviously brought this to a part 2 board before, so you have had a chance to comment on
lead for this street.
On the case
when you were out of the office over July and August.
And Hayat, as Debbie did say before.
Downs, Stephen.
I didn't see your lips move then,
the draft case for change has been through PIAC, and it has also been to Lancashire Place. And I think it also went to a scrutiny committee at Lancashire County Council sometime in the last few months. So we have in the background been trying to engage and consult with key people. And I know Neil and his team have done quite a lot of work on the population facing versions of some of this.
Okay, thanks, Sarah. I think when it does come back and we discuss the establishment of the joint committee, we have to think about any conflicts of interest that any members of the board may have in terms of the using of those services or living within that area. So think about that maybe at that time. Okay, I've got a few people have indicated. Have you got you first, David, and then Debbie, and then this David up here. So you, David.
Thanks, Sarah. I'm just some clarification. As I was reading the paper, we're talking about pre-consultation engagement, not consultation. I just want to be really clear about the differences, because presumably they want to take the case for change out, engage with people on the case for change.
Yes.
Then they would come back and write their business case, which would then go for approval, and then they would consult on that. So just we were kind of using the term a little bit interchangeably there. And consultation, I mean, there's just a difference, isn't it, between the engagement and the consultation? One's formal, one's informal.
Yeah. So we do have a formal duty to consult. So at the point, at the point where we've developed a business case that might outline some significant service changes, both ICBs have then got to formally, legally consult. So you've described it very well. So your description is accurate.
Thank you.
Okay, thank you. Debbie.
Thanks, Chair. So it's just to endorse, I know Sarah's updated and the report makes reference to PIAC having considered this. So again, it was just to sort of provide support to the case that we did have a look at it. We offered some feedback, all of which has been incorporated. So we were really pleased that Sarah James came along and presented and shared it with us. One of the points that we did make, and we registered it as a risk in the minutes, is that there'll be quite a few different either consultations or engagements around structural changes or services within similar footprints around the same time. So it was just something that I know that the comms and engagement team will be really conscious of, because there is always that risk of sort of confusion from a public perception when we're talking to them about several similar things or different things, and doing it really effectively so that we don't fall over ourselves really. So it's just quite that it's something that we're conscious of, that will be thought through, and how Watch Lindsay was with us in the meeting and was supporting around that as well. This is also very localised work that's happening, so we didn't want to confuse.
Okay, thank you. Dave.
I just wanted to check on the in the timeline, there was no mention of the NHS in the reconfiguration process.
Okay, so NHS England are fully sighted on all of this and are on the programme board for, so they're very aware. So there is a timeline. They have built in all of that transaction, but at this stage, we don't have to go through that process because there's not a business case that we consulted on and agreed.
But have you done the case for change to take through stage one?
Yes.
You've gone through stage
one? Yes, it's gone through stage one, yes.
It's just that the timeline didn't reflect.
Okay.
Okay. Basically.
Thanks, Chair. Yeah, slightly different way of looking at things, but I just wanted to make an observation really about place. We had a conversation in Blackpool on Monday about the lack of resources at place to be able to move the agenda forward. And I think where we've got this particular area of work that's clearly taken a lot of resource from the Central and West Lancashire place, I just wanted to make an observation that I think there'll be a lot of focus on this going forward. And what about Central? And that's just an observation, I suppose, at the moment around how we organised our places across our ICS area, because I'm quite conscious that we don't leave areas behind when there is a need to put resources into one area rather than another. I think we're in a particularly advantageous position in Blackpool, for example, because we don't border with anybody, we're a unitary authority, and maybe it's a little bit easier, but it's that comparison really between places, and some of the messages that are coming out around Central West Lancashire in particular is there's a lot of emphasis on sorting things out in West Lancashire because of this work that's happening, and actually what about Central?
Okay, thank you. Nobody else indicated presently. Sarah, anything more to add?
I mean, I'm not aware. I mean, I sit on Lancashire Place board with SACB and Sarah, who's leading on this, and there are still an awful lot of other work going on in Central as well. So I'm not sensing at this stage that that's a risk that's been materialised, Tracy. Now that doesn't mean, we talk about running staff survey next, staff are stretched, but at the moment I don't think this is negating from different work that needs to go on in Central, and there is quite a lot of innovative work going on in Central as well. So I think it's important we recognise it, but I'm not aware at this stage that it's a particular risk or that there's tension between Central and West, or that hasn't been flagged at the Place Partnership Board at this stage, is what I would say. So I think everybody's comments are highly relevant, but the thing I didn't say that I think, just to finalise, is a bit like we sometimes talk about fragile services and needing to get on with some of our work. Very much when that transaction went through and we supported that transaction, the urgent and emergency care pathways and the services for this trust stand around those populations are just as some of their most fragile pathways. So that's why they've prioritised urgent and emergency care. So I think it is important that we support, that we approve this today, and that we support Shaping Care Together moving forward with this area of work.
Okay, thank you. So Sarah's indicated 2 recommendations. Are we happy to approve those? Yes?
Thank you.
Okay. Thank you so much. Okay, that's all the business items on the items to note. Item 16 is the staff survey report. That's down you, Sarah, again.
Yeah. Thank you, Chair. So obviously the staff survey, I think it's really important. I know as a board we're all highly committed to establishing an open and transparent culture that supports our staff, and we've talked a number of times today, and there's lots and lots of evidence that if you don't have a thriving workforce and a supported workforce, then that actually directly affects patient outcomes and patient care. So it's very, very important. And the results in the staff survey, whilst there was a little bit of improvement from one year to the next as a new ICB, none of us would, these aren't the results any of us want to see in terms of where the organisation is. And the pulse surveys as well indicate that we've still got a lot to do as an organisation in how we support our staff. And whilst I think it's important to put some of this into context, and yes, forming a new organisation I think has been more of a challenge than many people would have anticipated. So the transition from 8 organisations to a new organisation has been very difficult, and in addition to that has happened at a time when, as we've heard today, particularly around urgent pathways, but we know across many pathways operational pressures are at unprecedented levels. We've got the impact of COVID, and we know the financial challenges. So all of those things are important for putting this into context, that staff right across public sector, it's not just the NHS, are working in very, very difficult times. And I know many staff will speak to me about that. I think people thought something would almost be a breath of relief after COVID, and things would feel easier. And actually the experience for staff right across public sector is that hasn't happened. And so really people have been working at a unprecedented level for quite a number of years now, and I think that is telling in the surveys. But even with that context, it's really, really important as a board and as an organisation that we own the findings in the staff survey and the pulse survey, and that we take them very, very seriously, which I know the board does, and that we do everything we can to address them. And I think what I just wanted to flag, that we are doing a lot, so what? We've got these survey results. We know that they're not where we want to be. So I think we have done an awful lot of work across the organisation since the survey results came out, and on the back of the pulse survey. But we also recognise, and I know Kevin's very committed to this, recognises there's still a lot to do. But just to pull out some examples from the report, we've got a number of staff wellbeing forums and staff groups that they can join to help them. We're having a lot of what we call big conversations, where each of us execs are meeting with our directorates, and then doing some specific targeted ones so that we can listen, really listen to staff and think about what we need to change. There has been a lot of change in the People's Directorate, but we are hoping to appoint a new CPO in the next few weeks. But also the team have recently just appointed a couple of new organisational development staff who haven't started yet, but when they do, they can really focus on some of this work. And I know Sam and Kevin have met and are going to bring in some external organisational development and culture support to help us. And we have asked a couple of our senior directors to take a bit of a lead on culture, and in particular one of the associate medical directors who I think from a taking staff with you point of view is very good at this thing. So I hope what the board here is some reassurance that we are doing a lot to address the findings in the staff survey, and that we are very committed to moving forward with the work that we need to do to make this absolutely the place that people want to come and work and where they feel valued and respected every day.
Okay, thank you, Sarah. Chief Exec.
Yeah, I just want to add and underline what Sarah said. Yeah, it has been a very tough 2 years. Don't want to cover what Sarah's already done, but we've got all the post-COVID performance challenges of waiting lists and so on. We've had strikes galore. In addition to the 8 CCGs coming together, we've also in-housed several hundred staff from the CSU, and we've brought in staff from NHS England. And in fact, we're getting more next year with the specialist commissioning as well. So our workforce has moved from, even though we've reduced our running costs by 30%, it's increased from about 450 to closer to 800. So you've got a very fragmented base there that's come together. At the same time, though, just as Sarah said, none of that's an excuse. We should be doing a lot better. And therefore, as the Chief Exec, I just want to be really clear with the board that we, the exec team, are not happy with the results. Actually, we welcome the findings. I think it's important to be open about it and see it as an opportunity for improvement. We definitely take them seriously, and we are committed to addressing them. And there are significant variations as well. Some units are performing actually really well, and some are really challenged. So it's actually quite a big spread. So, and that reflects that fragmentation that I covered earlier. But we are bringing in some support. It's obvious we need to do a comprehensive organisational development programme for our own workforce, and that work has now begun. Probably hindsight's a wonderful thing. That should have been done a year ago or so, in all honesty. But we are where we are. We've got findings that are challenging. We need to do something about it, and we're committed to it.
Okay, thank you. Anybody else? Okay, I'll take Jane first, and then you, Dev.
Not a great deal to add to what's been reported, but just to give feedback to Kevin, Sarah and colleagues that this is so welcome. This report could have been top of the list for me, because without an engaged, happy workforce, we can't deliver any of the things that are on the agenda today. And what I really appreciate about this is that we're not just giving reasons or excusing and saying, oh, it'll get better. We're systematically managing it. We've got a number of interventions that will make a difference. And I think, we just need to keep on top of that and track it. But what I sense is a real commitment to making this a priority, which is great. So thank you for that.
Thank you very much, Dev.
Thanks. I completely echo Jane's comments. Really, I think having such an open approach is really commendable. So I can see it was an uncomfortable reading it when you go through, and there was concern, but there was also a lot of reassurance about the solutions that are being put in place, and also that staff are engaged in those solutions, which is just so important, isn't it, in terms of the response. So my question against it is, I know that we've recommended that there's an update in 6 months' time. I actually wonder if there's value in having an update earlier than that. I'm just thinking that the full surveys are quarterly. They should give a really good indication on a quarterly basis of whether there's movement, whether there's improvement, and they could perhaps even be framed in a way to see if staff are feeding back to us that whilst everything's not being delivered, feel more confident that there's green shoots. It might be something that other board members might prefer to go to people committed to give us assurance, but I'm just thinking, given the significance of it and the importance and the value of the workforce, it might be something that we want to see earlier rather than waiting for 6 months, by which time, if we've not made the improvement, it feels like we've missed an opportunity again.
Okay, we'll pick that up, come back in a minute to Debbie. Angie.
Thank you. Well, I think firstly, let's just acknowledge some hard reading there, but some improvement. So, green shoots need to be recognised, and while this is not a unique organisation and your comparators have all been through similar, the amount of upheaval and change that everyone has been through and the national context, I think we need to recognise. What I was thinking about was I was actually in my mind linking this report with the next two reports as well, equality and diversity and complaints, and looking at the three together. There were some things that I would ask questions about. So, for example, I noticed one of the most important things in terms of driving up your engagement scores is to give advocacy and agency to individual members of staff. And I didn't specifically see in the bullet points where you were having those team-based conversations to really get under the skin of what's happening in individuals' teams and empowering the staff to make changes. So that was kind of my first question about the granularity of responses. The second question, because we do see a lot about bullying and harassment and ability to speak up, took me to the equality and diversity report, and I saw very high volumes of people choosing not to declare. Now that just could be because the systems are fast. It could be because actually people feel that they're threatened or they're disadvantaged if they make these declarations. Only you know that, but I think, you know, the answer is probably going to be a mixture of that. But I think that is something really need to keep a close eye on. And actually, there's quite a bit missing in the equality and diversion. In fact, there's very little in that equality and diversion there, particularly about things like your pay structures and your senior management structures and how actually are people able to progress in the organisation if they have some sort of protected characteristics. So none of that is there. And I think bringing that forward and bringing that into the conversation with your staff and being equally open and transparent about that would be helpful. And then the final thing is, you know, the complaints, because actually if it's an unhappy organisation, you're going to have unhappy residents. I didn't think your complaints looked really high compared to the numbers that I get at the county council, if I'm brutally honest with you. But there are no trends, which I think just reflects where we are in maturity because it's a new organisation. But again, we just need to look at the impact of that workforce issues on the public. So as we move forward, maturing those reports to give a more comprehensive narrative, I think will be really important for the board.
Thank you. Anybody else? Sorry, Tracy.
I think a lot of what I want to say that has been said. I think culture absolutely trumps everything else especially when you're looking at transformation. So the fact this is, you know, we've got this report that it's being scrutinised in this way, but I just really wanted to come back with some feedback because Sarah mentioned a few initiatives, the big conversation. Obviously, we've got the steering group. I'm hearing good things from people about the fact they feel it is being taken seriously, that it isn't good enough, that they are being listened to. And I'm just wondering if you go into a maybe organisational kind of review or look at some of the things that could come out of this, whether some of those recommendations could come back to the board, because I think there's a lot that could be done around this work. But I think the fact that this survey has taken place and there's been action already that I'm being told is actually, you know, really positive, is a really good thing.
Okay, good, thank you. Nobody else indicated. Sarah, I'll come back to you then, Chief Executive.
Yeah, just a couple of comments. I think the point about granularity was really important, and I think and it goes back to Kevin's point about variation. So I think that is happening in some areas and not in other areas. So, you know, I have quite a large area that I cover and I've done a number of engagement sessions, and overall actually the children trace feedback's good, but I know then there's the odd little pockets where a team might not be quite getting the same attention that is happening maybe in 80% of the areas. So I think we all need to go away and probe that a little bit and check on that. I'm going to come to the EDI report, but I think your comments on that, and there could be more in that, are valid. And again, I think this is the first one we've done. So we are an immature organisation that is maturing all the time, really, and getting better. And the last comment really on the complaints, and I know I've got to get to report, but I suppose just to put that in context, the complaints we get are usually about our providers because apart from probably all age continuing care, we don't have many of our services that are direct delivery services. So we don't get the full picture. And we get complaints about primary care, but we're not, again, we won't be getting all the complaints. So what you're not seeing there is all the complaints that are coming in across the system for the NHS, for the ICB. So I think it's always more challenging. Some people will write to the commissioner as well as the provider when they're making a complaint. Some don't, probably most don't. Actually, most will go directly to the source of where they got their care and make their complaint, and often only come to us if maybe they're not happy with the response they've had. So the complaints one is a bit more tricky than probably what you get, Andrew, which will be the full breadth of the complaints that come into the county council. Happy to share. Yeah.
Kevin.
Yeah, I don't want to add to what Sarah said, other than to say, actually, to put to look at it from a different angle. We've got very low sickness in the organisation. It's less than half what it is for the providers. It would be upper quartile for the public sector. It's probably way above the local authorities. It's in the threes. So that's very, very low. And our turnover is low as well. So we do absolutely take it seriously. There are issues that need to be dealt with here, but there are some positives there as well. I mean, our providers are 7, around just under 7, I think it is. So that's very, very low in terms of sickness level, and that does need to. That's a good indicator as well.
Okay, thank you. I want to say probably what I'd like to say on behalf of the non-executive member, I think I'm very much supportive of this, and Jane leading on this from the People Committee, and we thank you for your work on this. You and the executive team, Kevin. We recognise it's really important for not only the ICB, but for the system itself to recognise all that work going on. So I think thank you to both of you. Thanks, Sarah. Thanks, Kevin. Okay. So EDI report, Sarah.
Yeah, thanks, Chair. Again, this is for noting, but we are mandated to produce an EDI annual report, and like lots of things with NHS, it's quite specific, the mandate. But what the annual report that you've got a link to does is it does more than just what we're mandated to do. It just show some of the wider work that we're doing, and we've done quite a bit, but I think there is more to do. But we did develop a belonging plan last year, and there is wider work that's referred to in that annual report that shows the commitment across the ICB for this. But we also do recognise, I suppose, there's 2 elements to it. I recognise the comments made that we could produce more specific things in it. I think we also absolutely recognise we've still got an awful long way to go on this agenda, not just in the ICB, but as a system, in terms of equality and diversity, and in terms of having boards and teams within our organisations that are truly representative of our population. So I think this is a first go at an annual report, but recognises there's still a lot more work to do.
Comments? Questions? No? Oh, sorry, Debbie.
Yep. I suppose it's reiterating Angie's comment, because I did notice when I had a look at it, it shows it's the baseline data, isn't it? So for me, that's such an important building block of understanding the characteristics of the workforce, because it enables us to be proactive about things, but it also shows that we understand sort of what the workforce is going through. And I know when I've sort of had a look at the levels where staff were declaring against those protected characteristics, one of the highest ones was about disability, and there was sort of a reflection in the report that it's likely that there's more people who are disabled because we've got a high level of reasonable adjustments that are in place. So I guess as part of the development of the strategy, I've welcomed consideration of understanding why people don't feel able to share that, what we can do to sort of improve reporting, but also what we're doing in the meantime. I'd almost have an assumption where if we don't know, let's assume they are and let's do something about it, to be honest. So it's whether there's that gap in the level of risk around it in between
Okay. Anybody else? Sorry, Seth. Sorry, Shane here.
Yeah. So really helpful summary, and I like to think when you came to at the end, Sarah, that this is like, this is a work in progress, and there's clearly a lot more to do on this. I'm really pleased that we are coming alongside our people in terms of seeking to understand what it is that from their perspective will make a difference. And I think the staff networks and that sort of thing are really, really important, and look forward to seeing how those develop and move forward. I think the other thing is around kind of thinking about this as a system. So one of the things we tend to do with ED&I is, and it's not wrong, is we tend to kind of focus into organisations rather than looking across our population. And I think there's a lot to be gained from thinking about this in a broader sense than just from an organisational sense. And I think it's that whole bit about really understanding our population and getting that into everything we do, so that so it isn't just kind of done in silos into organisations, but it becomes absolutely sort of through everything we do, like words through a stick of rock, and thinking about that whole bit about how are we truly inclusive, and how do we make sure that we do that in everything we do. And that comes a thread through everything we've talked about today. Tracy's sort of bits around waiting lists and all of that. And I think it's a way of being, but getting into some of this stuff in terms of the understanding the tactical stuff to start off with into bits of organisation is still important. So it's both really. Yeah.
Okay. Thank you. Nobody else? No. Okay. Noted. Complaints.
Yes. So again, the complaints, we have to do a submission to the Department for Health and Social Care. And that's the submission you've got in the past. It has been to PIAC as well. I mean, I would say, again, this is a bit like the EDI work, and it isn't just the EDI work is for everybody, but we do have a small team driving that, just like we have a small team doing complaints. But these are very small teams who are under a lot of pressure, really. So it's acknowledging that. So I also recognise that, again, as we mature, I think the complaints report does what it needs to do, but probably we can build on it and it can become stronger. And we do recognise that. It's just another one that capacity. What I would say is the themes are similar to last year, but some of that we are taking learning from complaints. Some reports do go back into PIAC. We always triangulate them with the work that's coming through Quality Committee. So, for example, the improvement work we did on all age continuing care was very much also influenced by a lot of because we get quite a lot of all age continuing care complaints, although I do feel, because I sign them off, that they are improving, but we have taken the themes and the learning similar, the challenges around SEND and neurodevelopment often come through in complaints, so we are triangulating all the time what we're seeing in complaints. I've spoken here before about dental. We get a lot of complaints about dental, but I would say to bodies, we're not dealing with an incomplete isolation. We are taking the themes that are coming through from complaints and triangulating that with the various improvement work that's going on. So again, we're just looking really for noting that / approval of this so we can get it submitted to the Department of Health.
Okay. Anybody? David.
I've got 4 questions, Sarah. This is an area of special interest. Sorry. But our complaints tell us so much, don't they? They tell us where we're really making mistakes and getting things wrong with people. So it deserves being looked at. So I wondered whether or not you have any lay people involved in reviewing your responses, or whether you have anybody involved in independently reviewing your responses to complaints. That's something that happens in other places. And I wondered if you could just comment on your level of upheld complaints. It felt low to me, but I don't know how it compares to other places. It seemed that you only upheld a low percentage of the complaints. And the most important part of complaints, I guess, is learning. And I wonder whether or not you feel that we could evidence that the learning is actually taking place. It's easy. I mean, I run an organisation. It's easy for us to say in a complaint response that we've learnt lessons, but can we evidence it? Can we audit it back to something now different happens in a service as a result of the complaint letter that we sent to a person? I guess underneath that is how human are our responses? People that come to us often feel like the response they've had from the NHS isn't very human. It's very defensive or concerned about litigation or so. Yeah. Make from that what you will. Sorry.
Do you want me to
I'll
respond
just
now?
see if
or
anybody else. Oh, Jim.
There is a bit of an overlap with what David said, and I know we're noting this, but I think I'd like to see a bit more information on this in three areas, really, some of which David's mentioned. The first one is around the main themes, and you touched partly on that, Sarah, but this is more or less the only time of the year I see what's going on in the organisation in terms of complaints. So I would have liked to have seen what are the themes, and you had touched on a number of areas, so that was helpful. The second one was the lessons learned. And you described it better than I would have described it, but it would be nice to see what we've done differently as a consequence of these complaints. And the third one is the timeliness of reporting. Because if you're the kind of person who's complaining, you want a prompt response. So it's helpful to know whether we are managing to meet the timescales on that.
Okay. Burden of questions there. Anybody else got anything? Yes, Julie.
Ask for one additional part is how many of those complaints come from other healthcare professionals rather than patients. Because I think that it would be an interesting piece of information.
Yeah, it was about any other healthcare professionals. Well, no, bring those complaints. But they just 1 minute. Okay, anybody else? No. Okay, Sarah.
I'll do my best.
Okay, thank you.
So in terms of an independent review of responses at the moment, no, I don't. That isn't something we do at the moment, David. So I'll take that away back to the team because I think that's a really good suggestion. And I have worked somewhere before where we've done that.
That might be something we could help with.
Yeah, and also, well, I'll come back to explaining some how it works. But sometimes the main response is not our response. And that's the point I was trying to explain to Andrew. So if somebody writes to us and complains about care at Julie's GP practice, I'll use that rather than naming another provider, then we will contact the GP practice and Julie or her practice manager will draft the response. And that answers the main complaint with a covering letter from us because it's not about our service. If it's about one of our key services, so if it's about all age continuing care, then obviously one of my team drafts a response and the whole response is written by us as an ICB. So some of what you're saying about the personable side of the response and that we have more control over those ones. We do have one of our clinical care professional leads that works with us does sometimes does review some of them from an independent or another medical person, and he will help us with some of our covering responses. But we don't have a lay reviewer at the moment, so that is something I will pick up with you outside the meeting, David, because it's a really good suggestion. Your question about upheld and how do they compare, I can't answer that now, so again we'll get back to you on that. And also some of that will be about, it might not be us that haven't upheld them, it will be the providers and where they're at, but I will ask the team if they can break that down more for you and give you that information. And then to the learning, I think I can sit in and say for the areas that are very pertinent to us, so I quoted all age continuing care and autism, I think we are taking the learning because we're building it into then the transformation work we're doing, and particularly you remember all the papers I brought through board on CHC. Lots of what we did on the new model, as well as the engagement we did through some of the boards where we had users of the service involved. We did look at the complaints and the themes coming out and try and take the learning and the things that weren't working into that transformation. So I think that's probably nowhere near as good as it needs to be right across the system, because learning from complaints, and we discussed this at Quality Committee as well, it's not just learning from complaints, it's learning from patient safety incidents and safeguarding reviews. I think we still don't genuinely do that as well as we could. So I think there's more we can do there. Last on other healthcare, I don't think we get very many because I sign a lot of them off with Kevin or for Kevin, and I can't remember. So I think we get very few from other healthcare professionals about our services. They are, 99+% of the complaints I sign off have come in. We get quite a few, as you've seen in the report, via MP. So if a resident hasn't written directly to us, what they tend to do is go to their MP or local councillor who will then write to us with the complaint. So the two main sources are either the patient or their family member directly, or via MP offices. They're the main source of letters that we get in. Oh, and to Jim's point, yes, I'll take all that on board in terms of, and timeliness isn't in here, but I suppose that's my point about a very small team. And we had to make it's in here about PALS, but back to the human bit of timeliness. I think we are quite human in our responses, and the team are a very dedicated small team who do a lot of interaction with individuals, phone interactions, and navigate. They do an awful lot of navigating of individuals through complaint processes in the NHS. But as you can see, we had to cut that back a little bit because of pressures when the number of complaints rose. So we still do a bit of that, but we aren't doing a full PALS offer at the moment, just because of business continuity, and we're not meeting the timescales as we should be because of, again, the pressures in the team.
Oh, Debbie.
Yeah, just one additional comment really to support what Sarah said. So complaints, there is a standard report that comes through, an insight report that comes through to PIAC each time that we meet, one bit of which is complaints. But we also look at other insight, and what we try and do is triangulate what comes through. And the result of that, what we'll often do is we get a snippet of something, and then we do a deep dive into it. So primary care was a good example. CHC was another example where we could see that from different sources there were trends, there were patterns that were coming out, because we wanted more assurance on behalf of the board about what the engagement involvement and the position was. Dentistry was another example. So I think that there's a richness that comes through PIAC that perhaps haven't translated into the annual report. So there's definitely an opportunity to be able to bring some more of that through, to be able to share that with board and on an ongoing basis, really through AAAs where there are some insights.
Okay, thank you. Okay.
Yes, thank you.
Okay, thank you, Sarah. Item 19 is for me about the fit and proper persons test annual submission. Folks will be aware that NHS England published a new fit and proper persons test, and that framework came into effect on the 13th of September last year. This paper is just to inform colleagues that I responded to that with a submission and declaration signed off by myself and submitted to NHSC Regional Director on the 24th of June of this year. And so we've asked them to note the completion and submission of that annual submission. Are you happy with that? Yeah, that is okay. Thank you so much. Okay, any other business? I've not been notified of any other business. Oh, David.
Well, it's just a question really. Just we've mentioned a couple of times today about items being taken into part 2 meetings, and I wonder from a transparency point of view how we can help people understand more about that, the public understand more about that. At what point do you decide and how that an item should be held in a part 2 meeting and therefore exclude the public kind of view of that? I understand it must happen. Certainly in Health Watch, there are items that we can't discuss in public because we're dealing with people and stuff. So I really get it. But how can we just demonstrate openness and transparency to the public, but equally, describe why we're taking a thing into a part 2? I don't know if that's for now, but I wonder if we can maybe come back to that at some point. I just didn't know where else to ask the question.
I think most of the part 2 items become part 1 items.
Yeah.
In fact, we've got an example today where we looked at some of the underlying pressures on urgent and emergency care, and in September we'll be presenting a full report on that and updating our commissioning intentions. So normally it's sort of like things where it's either work in progress that we're still working through. There are some things where they are commercially sensitive around budget in particular, where we have a month, well, we're bi-monthly, we have a report at every board, but there are some areas that are confidential as part of that. So there's always an item on the budget issues. but most of the big items come through. So today we had a discussion on the whole sort of children's agenda, which we're going to do a report on, and it's a challenging area. And actually, it relates to the last item. It's one of the main areas where you get a lot of complaints through, and there's a major mismatch between demand, supply, and money, really nationally, and we experience that. So these things will be coming through. So we're not trying to.
I suppose it's not about the individual items. It's more about the process of how's that decided and how do we account for that to the public. So, the board has to do its business in public and, some kind of a register of what's taken in part two almost. We don't need a full explanation or the detail of what's been discussed, but just this paper went to a part two because of this reason. I think would demonstrate a level of openness that would just be really helpful.
Yeah, okay.
That's not comment.
Yeah, that's fine. That's fine. Yeah, okay. Yeah, thanks, David. Yeah. Anybody else? Any other business? No. Okay. Richard, just anything? Don't think there is anything. Anybody? No. Okay. Closing remarks from me then. Thank you very much, everybody, for your attendance and contributions this afternoon. Hope to see you all again very soon. That next meeting will be on the 11th of September, and after that meeting we have the AGM of the ICB. So those are very welcome to attend that, of course, as are members of the public. And we hope to see a number of you there on that particular occasion.
Can I just say that I think I've only missed one ICB meeting. Unfortunately, I'm taking advantage of the NHS and having a knee replacement on the 6th of August. So I don't think Will you excuse me, please, from the next meeting?
Certainly will. And we wish you good luck with that.
Thank you.
And I'm sure everything will be fine.
I'm sure it will.
Okay. Thank you. Okay. Thank you. Thank you very much. Thank you.